Okay, hello everyone, and thank you all for joining us today for the Future of Digital Health for Ending TB, a virtual forum, Day 2. My name is Alex Moran. I'm a technical advisor for data analytics at URC, and I work with the TB Care 2 project. I will be your moderator for the event. We're happy to welcome you back if you were able to attend yesterday, and if you weren't able to attend yesterday, we're excited to welcome you today. Yesterday, we gained some insight into the state of digital health technologies for ending TB from the perspectives of detection, treatment, and prevention. Today's focus will be on innovations in the private sector, data analytics for ending TB, and real-world implementation, for which we're excited to feature a panel of NTP leaders and TB survivors. A few quick housekeeping items. Attendees will be set to mute for the duration of the webinar, but will be free to use the Q&A function to ask questions. We ask that you reserve the chat function only for technical difficulties so that we can identify these quickly and provide support as necessary. Additionally, we have simultaneous interpretation available for Russian during today's sessions. Please use the interpretation button at the bottom of the screen and change the language from English to Russian to use this feature. Before we begin the presentation sessions today, we'd like to give a quick introduction to the TB Care 2 project and to describe how the project has contributed to the goal of ending TB. I'd like first to introduce Nicholas Enrich, the program team lead in the tuberculosis division of the Office of Infectious Diseases in the Bureau of Global Health at USAID Washington. Mr. Enrich leads the program and project design and management for USAID TB portfolio and serves as the AOR for multiple global TB awards, including the TB Care 2 project. He provides guidance to USAID missions on programming and management of their TB funds and projects, and advises the division and field on programming in accordance with USAID policies and regulations. So thank you for being here today. And with that, I'll turn it over to you.
Thanks, Alex, and good morning to everyone. It's my pleasure to join this forum today, which aims to share and highlight digital health technologies that are being implemented in improving health outcomes throughout the TB cascade of care. It's also my great honor to speak to you today as we celebrate the completion of the USAID TB Care 2 project. USAID is the lead agency within the US government to combat tuberculosis internationally. We work in 23 priority countries, working with host governments, partners, local organizations, communities, and the private sector to improve TB services. These efforts save lives and prevent the spread of TB, building resiliency among families and their communities, and preserving development gains across our partner countries. For over 20 years, USAID has focused its efforts and TB resources on 4 key technical objectives. 1, improving access to high-quality, person-centered TB, drug-resistant TB, and TB HIV services. 2, preventing TB transmission and disease progression. 3, strengthening TB services delivery platforms. And 4, accelerating research and innovation. Over the past decade, TB Care 2 has been a consistent and critical partner as the USAID TB portfolio has advanced and evolved. Through 2 5-year US government TB strategies, the introduction of the US National Action Plan to combat drug-resistant TB, and now into the era of the Global Accelerator to End TB, TB Care 2 has been there to provide cutting-edge support and essential contributions to the global fight against TB. From 2010 to 2020, TB Care 2 has provided global leadership and technical support to national TB programs and other stakeholders to accelerate the implementation of TB services. TB Care 2 focused on addressing gaps in service delivery and TB program management through innovation and scale-up of effective tools and approaches. These included expanding active case finding among vulnerable populations, such as minors, children, and people living with HIV or diabetes, strengthening laboratory networks, especially through the introduction of gene expert testing, and improving the availability, accessibility, and quality of treatment and care through integrated hospital and community networks, introduction of new treatment regimens, and services tailored to patient needs. The project also focused on developing digital technologies to ensure that patients always receive timely and appropriate services. During this period, we also saw that TB Care 2's contribution in palliative care and comprehensive care for patients with drug-resistant TB not only improved the patient's quality of life, but also improved adherence. TB Care 2 accelerated progress towards ending TB by fostering collaboration and partnerships to solve challenges to infection prevention and control implementation in high-burden countries. At both the global and national levels, the project brought together diverse partners, including ministries of health, labor and mining, private sector providers, manufacturing companies, technology firms, civil society and NGOs, academic and research institutions, and communities. By engaging multi-sectoral partners, the project worked to increase investments from public and private sectors while simultaneously building commitment and capacity. TB Care 2 also implemented field programs in Bangladesh, Malawi, and South Africa. The programs provided the opportunity to support the development and testing of innovative approaches to meet TB service delivery and program bottlenecks in diverse settings. Cumulatively, these programs supported the detection of over 760,000 cases of TB and 3,000 cases of drug-resistant TB, as well as substantial increases in TB and drug-resistant TB treatment success rates in these countries. TB Care 2 was uniquely positioned to both provide global leadership in TB and drive country-level implementation of innovative models of service delivery. The project conducted rigorous research to test and evaluate different approaches to treatment and care, fine-tune them through adaptation in other countries, and support their scale-up through global consultations and workshops. These investments have been instrumental as countries around the world are responding to the COVID-19 pandemic, using active case finding and contact tracing, leveraging laboratory networks, and supporting community-based treatment to avoid overwhelming health facilities. I would like to conclude by thanking the Ministries of Health, national TB programs, our partners and stakeholders, as well as the wonderful TB Care 2 team, whose tireless efforts have resulted in the successful completion of this project. USAID remains more committed than ever to supporting sustainable national efforts to curb the TB epidemic in high-burden countries, as we continue to work with governments, civil society, and the private sector in our partner countries to accelerate their response to end TB while ensuring they are progressing along their journey to self-reliance. And with that, I'll turn things back over to URC. Thank you.
Thanks very much, Nick, and thanks for all of those insightful thoughts. So next, I'd like to welcome Halaja Al-Masawi, the Acting Project Director for TB Care 2, to deliver some additional opening remarks for the day.
Thank you, Alex. Good morning, good afternoon, and good evening, everyone. And thank you for joining us once again as we reflect on the landscape of digital health technologies for ending TB and look toward its future. In 2010, USAID set out to complement and build upon its existing and planning projects in the Bureau of Global Health to provide global leadership and support to the national TB programs and other in-country partners through the USAID TB Care 2 project implemented by URC and a wide consortium of health and development organizations. As part of TB Care 2 team, I had the pleasure of watching the project growing tremendously over the past 10 years. Thanks to USAID, what started as an ambitious goal to reduce TB has now successfully impacted the lives of tens of thousands of TB patients across the globe, not to mention their families, communities, and of course, their healthcare workers. URC has worked with the US government and other partners in other countries to advance health and development outcomes for 5 decades. We work to achieve US government strategic health priorities, including combating infectious disease. With expertise in quality improvement, health system strengthening, social behavior change, and research and evaluation, we have been providing technical assistance and global technical leadership on key focus areas, including TB, DRTB, infection control, and prevention. Through TB Care 2, we have been assisting project stakeholders to accelerate the implementation of TB DOTS, TB HIV, and the programs for programmatic management of DRTB in over 19 countries, with program implementation in Bangladesh, South Africa, and Malawi. Throughout all of these interventions in the past decade, TB Care 2 approaches have worked to foster self-reliance in each of our partner countries by building commitment and capacity among health workers, communities, and their leaders, endowing them with the knowledge and the tools that they need to respond to the needs of the population, confront challenges, and providing lasting development outcomes. Among these tools is the ability to leverage technology to make development more effective and efficient, deliver information and actionable insights, and close digital divides, ultimately making development outcomes more inclusive. We believe in the potential of digital health technology. As a result, we have leveraged digital solutions to build up global learning resources, accelerated collaboration and coordination, strengthen health system, and put patients at the center of our services and care. On behalf of the TB Care 2 team, I would like to express how grateful I am for USAID's investment and partnership. Without support from USAID, we would not have been able to achieve such a robust success. After a decade of investment in TB, detection, prevention, and treatment, me and my team, all URC team, is very proud when we look back on all that this project has accomplished. With that in mind, I would like to thank you all again for engaging in these important discussions. Following this presentation, we would like to share with you a short documentary about TB Care 2, after which you will hear about more exciting innovations in the private sector and data analytics, wherein lies the key to truly accelerating and sustaining the results we all wish to see. I look forward to another day of learning with you and together building on our collective foundation of knowledge and experience to work toward a time when we can put an end to the unrelenting public health problem of tuberculosis. Thank you very much. Thanks, Alex. Over.
Great, thanks so much. I think we'll play the video now. So we'll get that loaded up. Thank you.
Tuberculosis remains the world's deadliest infectious disease, taking the lives of about 4,000 people each day. About 1/4 of the world's population has latent TB, and infected people have a 5 to 15% lifetime risk of falling ill. TB has a devastating impact on development and exacerbates poverty, which places economic and social strains on individuals, families, and communities. Fighting this disease that causes millions of people to suffer and die each year has not been easy due to several factors: delayed diagnosis, weak laboratory services and healthcare, high-risk comorbidities, challenges of drug-resistant TB, DRTB. United States Agency for International Development, USAID, leads the U.S. government's global TB efforts by working with international agencies and partners around the world to reach every person with TB, cure those in need of treatment, and prevent the spread of new infections. In 2010, USAID launched the TB Care 2 project, implemented by URC and partners, which aims to provide global leadership and support to national TB programs and other stakeholders to accelerate the implementation of TB, TB-HIV co-infection, and multi-drug resistant TB services, while focusing on innovative technological approaches to improve TB case detection and treatment, with a particular emphasis on interventions related to infection control and programmatic management of drug-resistant TB. From 2010 to 2020, TB Care2 developed, implemented, and scaled up innovative TB interventions at the national, regional, and global levels. USAID TB Care2 provided technical support to the high TB burden countries, including those prioritized under the U.S. National Action Plan for combating multi-drug resistant tuberculosis, implementing in the following countries: To fulfill the global venture, URC's strategy for implementing project activities is based on key core principles. TB Care2 has contributed to successful design and implementation of interventions to assist countries in their fight against TB. In Bangladesh, TB Care2 worked at the national level, and in 39 districts, the project piloted and scaled up innovative models for community-level TB service delivery, engaged non-governmental organizations, NGOs, and the private sector to accelerate TB case finding, supported the integration of TB services with diabetes, HIV, and maternal and child health, MCH, and strengthened the overall health system for aid TB service delivery. Understanding barriers to diagnosis and treatment from research to practice. Community engagement in TB case finding. Active case finding and infection control at health facilities, FAST. Building health provider capacity for diagnosis and treatment. Strengthening laboratory networks. Improving adherence to MDR-TB treatment. Health treatment support. Integrating TB with HIV and diabetes services. In Malawi, TB Care2 worked to expand and solidify achievements, especially around increased case finding, decentralization of TB and MDR-TB services, and improvements in TB-HIV integration. Engaging communities in TB control. Expanded TB case finding at health facilities. Strengthening the laboratory network to support TB diagnosis. Decentralizing TB registration and treatment initiation. Promoting integrated TB-HIV services. addressing multi-drug resistant TB. TB Care 2 made a strong contribution to strengthening TB control in South Africa, increasing demand for TB treatment, improving case finding and management of TB in children, strengthened MDR TB case finding and management. Thanks to USAID, millions of people were reached with TB messaging and thousands screened and tested for TB and HIV. Since 2000, USAID and its partners have saved more than 58 million lives globally. USAID TB Care 2 has reached its goal for the year 2020 by developing and scaling up innovative models and providing targeted technical assistance to the countries with a high burden of TB in accelerating progress toward ending TB. USAID continues to lead the U.S. government's global TB efforts to reach every person with a disease, cure those in need of treatment, and prevent the spread of new infections and the progression to active TB disease, and to accelerate their responses to end TB while ensuring they are progressing on the journey to self-reliance.
Great. Thank you very much to everyone for the insightful remarks, and thanks to everyone for being a part of the TB Care 2 project through this event and over the years. I'd like to take this opportunity just to highlight the impressive poster presentations on the forum website. Our colleagues have reported some very interesting findings and have really gone above and beyond on the quality of these posters. So we encourage you to take a look as soon as the sessions conclude. These will be on the website. I think we have the link on the next slide. Perfect, yeah, and I think we can get that in the chat as well, so you can click it directly. But definitely take a look at these. There are some really great submissions and a lot of different interesting findings being reported, and clearly a lot of effort has gone into these. So definitely, as soon as the sessions conclude, it would be time well spent to take a look at them. So with that, our first presentation session today will describe some novel private sector innovations. We've collected some really interesting speakers for this set of presentations. So without further ado, I will introduce the moderators. The moderators for this session are William Wells and Amira Khan. Dr. Wells is a senior TB technical advisor at USAID, and Ms. Khan is a technical advisor for TB Reach with the Stop TB Partnership. So thank you to both of you for being here today, and I'll hand it over to you.
Hello, everyone. Welcome to session 4. My name is Amira Khan, and as mentioned, I'm with the TB Reach initiative with the Stop TB Partnership. So this session is innovations in the private sector. The private sector plays an essential role in healthcare delivery in many countries, and private providers are often the first point of care for people with TB. Additionally, community engagement is also crucial for the TB response. So in this session, we'll hear from 5 presentations on using digital innovations to help engage the private sector as well as communities in the fight against TB. I'm going to turn it over to my co-moderator, William, to introduce himself as well as the first speaker.
Great, thanks so much, Amira. Good morning, good afternoon, and good evening. Thanks to the organizers for including me in this very interesting event, and welcome to everyone for this second day of presentations and discussions. So the question for this session is, how do we use technology to engage private providers in the provision of quality TB care? Before we get started, I wanted to highlight 2 things. First is that we should recognize that technology has already been particularly critical for private provider engagement because it addresses the numbers problem. That numbers problem, put simply, is that there are too many private providers and not enough staff to engage all of them individually through each step of the TB cascade. However, technology can multiply the efforts of a few provider engagement staff, thus creating efficiency and potentially scale in private provider engagement. Put simply, with technology, you can reach more private healthcare providers and thus reach more TB patients. In addition, you can use technology to tie together the various elements of screening, diagnosis, treatment, and patient support, which in the private sector may be contributed by several different types and individual providers. We saw an example of this yesterday in the talk about the TB Star app in Nigeria, which tied together these different provider types. And then the second issue I wanted to raise is a more in-depth focus on this question of reaching scale. Through yesterday's talks, there were many intriguing innovations, but there were several examples of technologies getting stuck at pilot stage, and there was relatively little discussion of the pathway to scale. Private provider engagement has been there before. Over the past 15 to 20 years, we've had many pilots. And for the past several years, the PPM community has been emphasizing scale-up pathways as the critical issue to resolve. USAID support for private provider engagement tries to catalyze efforts on both sides of this scale-up issue. We fund small grants for private provider engagement efforts through TB Reach in order to increase the pool of local organizations who are skilled in private provider engagement. And we also work at the health systems level to understand and influence the pathways to system-wide adoption. So as we listen to and discuss the upcoming presentations, I hope we keep in mind this issue of the pathway to scale and how technology can be one element on that journey. So given that context, I'm delighted to introduce Luan Vo. Luan is chairman and founder of Friends for International TB Relief, or FIT, and senior technical advisor for IRD Vietnam. Among other activities, FIT is piloting a private provider interface agency that aims to improve private sector transparency and quality of TB care. Luan, the floor is yours.
Hi everyone, my name is Luan and I have the pleasure of presenting on behalf of Friends for International TB Relief on our private provider engagement work in Vietnam called Proper Care in the Private Sector. Before I begin, I'd like to say a quick thank you to USAID and the TB Care 2 activity for allowing us to share our work with you all today. The presentation today will consist of 4 parts. First, an introduction on the scene in Vietnam and what the TB burden is like. Then I will speak about our proper care in the private sector results and project impact. Then I will speak about the digital technologies that we employed for enhancing our private provider engagement. And lastly, I will go a little bit into the impact, the conclusions, and of course, make a few acknowledgements. Vietnam is a high TB and MDR TB burden country, ranking 11th on both indicators. Each year, there are about 174,000 new cases, of which around 100,000 are notified and treated by the NTP, which suggests that there's a treatment coverage gap of around 43%. And based on some onion modeling, it is estimated that about half of these 75,000 cases are treated but not notified to the NTP. Despite the high share of underreported cases, the number of TB cases contributed by existing PPM schemes to national notifications has been pretty low. In 2017, that number was only 8% of the entire nation's notifications. And if one breaks that further down into public and private sector, the contribution from what we would consider true private sector was less than 2%. In response to the gaps in private provider engagement, FIT piloted a PPIA model called Proper Care in the Private Sector from 2017 to 2019 in 2 districts in Ho Chi Minh City. Since Shibu and Path will talk a little bit more about the details of a PPIA model, I will only go into the characteristics of PCPS, which included 2 strategies, the traditional referral strategy, as well as the ability for doctors who actually treat TB patients in their private practice to continue to retain their patients and simply notify this treatment. with the core value proposition of availing expert testing to everybody participating on the project through what is locally known as the double X diagnostic algorithm that only requires chest X-ray abnormalities in order to access expert testing as a confirmatory first test. And in addition, provide services to these participating providers to minimize the impact on their own economic productivity, such as field staff and hotline support, sputum collection and transport, recording and reporting support, as well as clearly the retention of clients and the payment of incentives for referrals and notifications. By employing such an intensive private provider engagement model, we were able to get 126 providers of the 1,107 licensed providers in those two intervention districts to make almost 5,000 X-ray referrals that then resulted in 162 cases detected. And then amongst those 162 bacteriologically confirmed cases detected, 91 were then transferred to the NTP for treatment. Meanwhile, in these two districts, we even got 14 private providers to provide us with TB treatment data for a total of 1,112 persons treated privately for TB in their practices. And not only did they report these cases, but then also their diagnostic basis and their treatment regimen. And from that, we saw that there was actually quite a high rate, almost 70% of clinical diagnosis, which was also observed in other settings, but also implies that we can do better in terms of diagnostic quality and reduction of potential overdiagnosis. Meanwhile, only around 2/3 of patients were treated with the standard NTP sanctioned first line regimen, while almost a third didn't have duration reported or were treated with ancillary drugs such as streptomycin or even levofloxacin. Nevertheless, those results showed us that there is actually quite a bit of private sector TB treatment, and that if you were to include all of these cases in official notifications, that could have a substantial impact. Only just adding the officially reported 91 cases or the officially transferred cases resulted in an 8.5% increase. And had we been able to include the private treatment reports, which we did not due to legislative barriers, but had we been able to include those, that would have been a 68.3% increase in notifications over the intervention period in these two districts. One of the key electronic or digital tools that we employed during our work was the Access to Care Information System and Health tool developed by the Clinton Health Access Initiative and a local shop called TechUp. And this tool we used for screening, referral, as well as case-based surveillance. The unique feature of this tool is that it's bidirectionally linked with the NTP's electronic recording and reporting tool called VitaMess, which means that as soon as a new case gets notified in VitaMess, that case gets entered into ACES, generating a running task list for community health workers or other staff to conduct contact investigation. And once they do so and actually screen and refer somebody, these data and the patient information can be then transferred back into VitaMess in order to reduce the burden of double data entry for the public health staff, as well as can be used to enter additional testing data and screening data for tracking and making sure that all persons screened eligible are receiving the necessary tests that are ordered, as you can see on the right side. And then the other point is that at the moment we're scaling up this project and we're building an interface, a web interface where private treatment notifications can be reported in this tool, which then can be pushed into the NTP's routine surveillance system. The other digital tool that we used, again, a process tool, but very, very useful for our purposes, was a CRM software called CRM Viet that we adapted from best practices from the pharmaceutical industry, where we essentially loaded or preloaded lists of registered private providers as well as other mapped private providers into the system and used the system to track to track all of the field staff activity, ranging from engagement, phone calls, visits, to more significant encounters like signing contracts, in order to be able to see how well we're performing in terms of coverage, as well as in terms of engaging these private providers. And we'll be using this tool to then look at which private providers we've signed a contract with, but who have not elicited any type of referral or notification, to be able to go back and target them for perhaps another round or two of intensified engagement, and thereby optimizing our activities. Here are a couple of other examples where we've tried to employ digital tools on our project that either have too limited of a sample size to be discussed here, or are going to be talked about by others who know much more about them. But in essence, we are working with Cure and other providers to test out an AI surveillance model in general healthcare settings, as well as occupational health screening settings. We've worked with Swipe on a very small but quite effective pilot on using their social networking platform to engage pharmacies. We've engaged marketing companies to develop social media campaigns and an online presence, which even resulted in the detection of TB cases 1 or 2, as well as worked with Sure here to try to pilot a VOT in the private sector, which wasn't all that successful, but showed at least that there were key factors that can be identified and that can be stressed in order to increase acceptability amongst private providers. So what was the impact of this implementation of this PPIA? So the PPIA, as I mentioned, is currently being scaled up together with the NTP to 9 districts across the country, but also PPIA and private provider referrals or notifications in general, actually not referrals, but notifications in general, were considered one of the core strategies that could bring about the end of TB in Vietnam, as modeled out by the Time Modeling Group. And as such, PPIA was included in the National Strategic Plan, as well as the Global Fund funding request for 2021 to 2023. In conclusion, this project showed that private provider engagement is critical for ending TB in Vietnam, and that this engagement can be optimized through technology, which in the end can help us enable a greater transparency into the treatment coverage. Where do we still need to do work, as well as give us an opportunity to improve diagnostic and treatment quality outside of the traditional NTP network. As for next steps, in my opinion, it is necessary to develop guidelines and policy for a new PPM model, Model 5, that allows private providers to notify cases as it has been done in other settings, as well as the expansion of activities throughout the country through additional sources of funding. We would like to quickly acknowledge our sponsors, like USAID, the SOP-TB Partnership, our government partners, such as the NTP and the various departments of health, as well as our implementation partners, such as CHAI, IRD, and so on and so forth. But most of all, we want to thank our patients and our communities as we strive to work with them, engage them, and support them to end TB.
Thank you so much, Juan. Great presentation. So if anyone has questions, please put them in the Q&A box. We've got one coming in already. So just to start things off, I'm wondering if you can talk a little bit about the effort required to establish a PPIA versus maintaining or running a PPIA, and how did you kind of navigate that with different funding sources and expectations around immediately achieving results? And also, how does that translate to other organizations taking up this effort in Vietnam as well as your own? Is the intervention too complicated to navigate these issues, or somehow it's manageable? Thanks.
Thanks, William, for the question. And again, thanks for URC, USAID, and the organizers for allowing me to speak. The biggest challenge in starting this was actually the timing at the time, because PPIA was in Vietnam still quite a novel concept and is not included as a valid model in the current PPM legislation. So it was actually the pilot phase was the hardest part, was to engage providers and convince them, but then at the same time also to engage the NTP first at the provincial level and now at the national level, and convince them also of the benefits of a notification system or a strategy that would allow doctors to retain their patients. So I think for us, the hard part was creating this kind of almost establishing a market or building a market on both sides, on the provider side as well as the NTP side, and getting buy-in. I think with the question about scale up and going forward, I think now the road is laid almost, and that there's been more acceptability on the NTP side to do this work, which is critical, but also on the providers getting to know more about what their benefits are, and specifically the access to expert testing for their customers has been a key value proposition to them. So I think that if there are more organizations willing or interested in replicating this type of work, I think the road has been laid. That doesn't mean that it's not going to be difficult, because the biggest, really, one of the key challenges, as I mentioned, is engaging these providers and getting them to trust you. Given that the legislation isn't quite there yet, they are actually exposing themselves quite a bit to some level of risks. And so one of the key points is to build this network and to assure them that confidentiality will be preserved, and making sure that you stick to your word. So I think that it's going to be easier for anyone to replicate, but it's still not easy per se.
Great, thanks, Luan. There are a lot of good questions here, and I think those will be, I think Luan can respond to those in the chat directly. But maybe just to briefly mention, combine two of them. You mentioned a number of different tools, and then private providers have their own tools. So how's all of this harmonized? And then you've also got the NTP side as well. So how does this all come together into a coherent whole? And how do you manage patient confidentiality through that process?
Yeah, so during the pilot process, it was actually quite a mix, or a lot of manual labor using data extraction or just managing lists on Excel. And what we really wanted to do is create a system like Nikshay, which is already integrated into the electronic reporting and recording system from the NTP. So with that ACES tool, we essentially try to harmonize with the NTP by sitting down with their M&E team, by identifying the core variables that would be required based on WHO guidelines, but also based on what the NTP really wants in order to be able to count a notified case, and then to build that linkage through API connectivity between this ACES tool and VitaMES. And ACES eventually will be then, and this has been agreed already, will be transferred to the NTP. And so that hopefully resolves the problem of harmonizing with the government system. Now, with the private providers themselves, it probably will take a bit of time to advocate for the use of this tool. This tool also comes as a phone app, for example, and to get them to adapt it and then to use it. And I think that that's something that was observed also in many other settings, that just takes work and time. But I think that is something that's critical for being able to scale to the national level and engage providers, not by us reaching out to them, but by eventually them seeking and then self-registering and then working with this tool and the NTP directly. Of course, these are all very aspirational goals, but I think if we don't aspire to achieve that, we shouldn't be aspiring to an NTP. But yeah, I think it'll take some time and some work, but working with the NTP first, creating a tool that's linked to theirs, and now making sure or bringing this to the market and hoping that providers will engage and use it.
Great, thank you so much, Luan. I'll hand back to Amara for the next introduction.
Thank you.
Thank you, William. So our next presentation is Digitally Empowering Pharmacists to Find and Fight TB. This is presented by Farouk Merali. He is the CEO of M Clinica, Indonesia and Philippines. It's a healthcare startup connecting pharmacies in emerging markets through a common mobile technology platform. and it operates across Southeast Asia, connecting over 40,000 pharmacies and 170,000 pharmacy professionals. And with that, I'm going to turn that over to you, Farouk.
Hello, everyone. My name is Farouk Morali, and I'm from Clinica Pharmacy Solutions. Today, I'm very excited to share with you work that is being done to digitally empower pharmacists to find and fight TB. In the Philippines, 40% of TB patients self-medicate. According to the 2016 National TB Prevalence Survey, it showed that over 40% of symptomatic patients did not go to health centers, rather bought medicines at pharmacies and self-medicated. What this means is the pharmacy becomes an exceptional channel by which to identify potential TB patients, ensure that they are properly counseled, and referred to health facilities for confirmatory testing, ensuring that they and their communities are healthier. In phase 1 of this implementation, which began in 2019, Clinica, through funding by USAID and led by TB Innovations, facilitated the participation of private sector pharmacy professionals in TB screening and referral through the SwipeRx e-referral program in District 1, Manila City, Philippines. SwipeRx is the largest digital professional network of pharmacy professionals in Southeast Asia. Across the region, over 170,000 pharmacy professionals from 40,000 pharmacies are already engaged. In the Philippines alone, 1 in every 2 pharmacists is on the app, making it an amazing channel by which to deploy technology and tools to empower pharmacy professionals to better serve patients and manage their pharmacies. The SwipeRx e-referral program began in June 2019 and is ongoing. The implementation partners were the Philippine Department of Health, Manila Health Department, Metro Manila Center for Health Development, USAID, Clinica, and FHI 360. With these partners, we engaged 32 chain and independent pharmacies, having heavy engagement in the private sector and ensuring their relevance to this program. In terms of the health facilities, there were 12 implementing partner health facilities. These are the facilities that pharmacies would refer to under the SwipeRx e-referral program. There were 10 district health centers, 1 private hospital, 1 public hospital, and the pilot implementation site was in Manila City District 1, a 4.57 kilometer squared area in Tondo in Manila. So this shows an exceptional amount of partners from the private and public sector all coming together with the simple goal of identifying TB cases through the pharmacy. To give you a background on the timeline, from start to launch, it was only a 3-month period from mid-June to mid-September. And what's incredible is during that period, there was design and development and testing of the application and the function of e-referral. There was all the mapping and engagement of the stakeholders, the pharmacies, the health facilities, as well as the numerous partners involved. And it led to a final culmination of launch and training of pharmacies that began on September 17th through a kickoff and official start of the program. And I think this is an incredible achievement and great support of all partners to bring private and public sector together around the pharmacy in such a short period of time. So let me take this opportunity to explain how the e-referral program actually works. So a client, perhaps having a persistent cough and fever, now visits a pharmacy that's on the SwipeRx e-referral tool. The pharmacy professionals have been digitally trained and educated and are able to now perform an initial screening with the patient, understanding their signs and symptoms, and realizing which clients have a high likelihood of having TB. Once confirmed, the pharmacy professional is able to register the patient into an e-referral program, which then provides the patient information on which facility to go to, the closest one to them in the most convenient location. The client then presents at the health facility and is able to actually go through confirmatory testing. The entire pathway from client visiting pharmacy, from the client going from the pharmacy to the health facility, is digitally tracked all the way to the health outcome. So this becomes an incredible method by which to quickly in under 30 seconds, register a patient and e-refer them to a health facility, and be able to track the entire funnel from presentation to actual result. And I think what's exceptional here is that when we looked at February 2020, after running the program, 65% of formally trained pharmacies had at least one presumptive pulmonary TB patient who was registered into the tool. What's even more shocking is that 54% of the cases referred from pharmacies to health facilities were positive for TB. This is an exceptionally high rate of TB positives in the community. And without the intervention of the pharmacy through this technology, these cases would have been missing. And I think what it goes to show is that pharmacy professionals are incredible screeners of patients. And if given the right tools, technology, and if bringing the right partners to bear, they can be a very untapped source of missing cases. They're able to identify, counsel, and refer patients very effectively, as we see by these results. And so I think what this shows you is the power of an intervention that is digital, but also the power in tapping a channel that is not often tapped in TB care. And so, this becomes an exceptional intervention by which to scale up. In terms of next steps, it is now about scaling this program nationally. We will be doing so in concert with the Philippine Pharmacists Association, the body representing pharmacists nationally, and helping to scale up the SwipeRx e-referral program. In addition, we will be strengthening education and training through online continuing professional development, which will be accredited by the Professional Regulation Commission. This will allow education to be delivered at scale online to pharmacy professionals regardless of where they are in the country. And in doing so, we hope to strengthen the capabilities and competencies of pharmacy professionals in dealing with TB and help to find these missing cases. Thank you very much for the time today. It was a pleasure sharing with you the amazing results from all the work we have done together. Thank you.
Thank you, Farouk, for that interesting presentation and that very interesting tool that we're looking forward to hearing about the expansion of. We do have a few questions that are coming in through the Q&A, but I don't think we have much time to answer more than one. So one question I do have is, did you experience any challenges encouraging the pharmacists to use the apps? What were your methods of engagement? In other interventions that we've seen where pharmacists have been engaged, there's been quite a bit of challenges unless there were some incentives offered to them.
Yeah, so thanks again for the opportunity. Thank you, USAID and URC, and thank you to my fellow panelists. Lamont, you've done some great work as well in the pharmacy space as well. So just to answer this question, and then I'm happy to answer other questions on text as we move forward in the time. But effectively, in terms of apps, I think one key consideration is, you have to go to where they are already. And I think the benefit of having a platform like SwipeRx was that pharmacy professionals were already using it for education, for Q&A, for connecting with one another. And so you had this existing platform that they were using. So when it came down to a TB specific aspect, then putting that within the platform could work. And I think it comes down to, we in the TB community may care and think about TB all the time. A pharmacist doesn't. They're dealing with every single disease, of which TB is one of them. So how do you get them at a platform that is helping them to do their daily professional practice, that's helping them educate them about all diseases, and how do you actually fit TB-specific programming within it? And I think, with the work that was done with USAID, FHI 360, NTP, and the like, really being able to understand the pharmacy viewpoint, highlighting their role as professional heroes or those that are not often tapped for this, and driving that to a good outcome was certainly possible. So I'll pause there, and I think I'll take the rest of the questions on text then.
Great, thank you very much, Farouk. So it's my pleasure to introduce Dr. Shibu Vijayan. Shibu is based in India. He's the Global TB Technical Director for PATH, and his work has included demonstrating a successful model for the Patient Provider Support Agency, or PPSA approach. and we look forward to the updates on his work today. Shibu, please go ahead.
As you all know that India have a huge unregulated private sector, and that poses challenge to the TB control. In private sector in India is very plural, starting from informal doctors to partially qualified to basic MBBS qualification, and then higher internal medicine or MD doctors. So 70 to 75% of the TB patients are estimated to be approaching the private sector as the first point of contact, and a significant proportion of them either not get detected or get wrongly diagnosed or wrongly treated by suboptimal treatment. This is essentially due to inaccurate diagnostic methods in the private sector and ineffective and highly varying drug prescription patterns, which is evidence and publications are there. And there are no systems of treatment follow-up and adherence tracking in the private sector. This triggers drug resistance. And as you all know, that Mumbai has a huge burden of drug-resistant tuberculosis as well. So irregular dosages, untreated strain, trigger drug resistance that add burden and more trauma to the patient, not only for consuming the more time and resources, and also the sufferings attached to that. So National TB Elimination Program also had challenges in engaging private sector. However, early on in 2003 onwards, the TB Elimination Program in India designed programs and guidances for engaging the private sector. Essentially, most of these programs are envisioned to refer the patient to the public system where the quality service is available, or even establishing access to the publicly available goods, diagnosis, and drugs. But this had a mixed response, essentially because of mistrust between the two parties, the public and private. Given that PPIA model was envisioned by Government of India and articulated that in the National Strategic Plan in 2012-17, and it also committed, the Government of India also committed to test it out, and Mumbai 2014 given path and opportunity to formulate a PPA model, as I mentioned earlier, in collaboration with WHO and National TB Elimination Program and the local government over there. So before starting of the project, we undertook a mapping, which includes listing of all the facilities, doctors, diagnostic centers, pharmacies, hospitals across 15 wards. 15 wards were selected because of the high slum population and high TB burden. And so after listing, we also understood what are the referral patterns existing and what are the approaches for diagnosing of any lung AML, for that matter, existing in Mumbai. So then we designed this model called hub and spoke. So as you see, the spokes are mostly the informal doctors or first line care provider. They are more prevalent, less expensive, mostly $1 to $2 doctors, and mostly on a relief-based care. So you see that there are referrals happening between spokes and hubs. So we leverage on that model. So the moment a presenting TB cases walks into a spokes clinic, the spoke register. So I'm going to mention about what were the IT structure we used here, which is UATBC, which is an application supplemented the model for beneficiary registration and voucher generation for services and treatment adherence tracking. So how this function is that either the spoke will have access to this application through his mobile or laptop, or he can actually call a call center, or he or she can call a call center and get a voucher generated. So typically how it functions is a patient with a presumptive TB symptom walking will get verified by the doctor. and if he falls into that category, patient will get an access to, will get an electronic voucher for an X-ray. So he or she will walk into an X-ray facility, either in a hub center or outside a standalone X-ray facility, and show this voucher and redeem this voucher for X-ray. So the service is free to the patient, and the doctor verifies the X-ray report, and if it is indicating TB, or even patient doctor clinically recognizes this patient need a higher doctor referral, he'll get referred to a higher hospital, which is hub hospital, or it could be a clinic, or it could be a facility, it could be a co-located, or it could be closely near in the neighborhood. So the patient reaches here, and then the doctor again verifies over there. Then moving on, some of the requirements, the call center, how it looks like, the patient, that as I mentioned earlier, the doctor gives a call for drug voucher generation. The patient gets, and the provider gets the voucher, patient information, patient ID and the voucher ID to the phone. Either the provider can, if the patient is not carrying phone, the provider can transfer or write it down, the voucher number, and the patient goes to the respective service outlets and get the right services. And let's say if it is a drug voucher, the chemist will have to go call the call center and confirm, hey, here is Shibu with 1234 is the voucher number, is a valid patient or not. Once that validation has happened and the drugs are issued, then the patient will receive the SMS services, as I mentioned earlier, for intake and also refill reminder calls from the call center. And at the end of the month, the chemist or even lab or X-ray facility will generate a invoice and inform the system that this is the payment is due, and then subsequently the system can trigger payments once it is validated. So the results so the impact is creation of unique ID for beneficiaries, providers, and field staff. So every provider were identified by the ID. Every patient had a unique ID, and also the field staff attached to each patient also had IDs connected to link to the patient IDs and the provider ID. So the network is created, all were networked through this digital architecture. Notifications from the TB cases were automatically happening once the patient is confirmed, and that information is plugged into the system. System will automatically prompt whether it needs to be notified or not. So with a click, this information does get pushed into the Government of India notification system called Niksha. Drug vouchers were generated and approved for and only with approved drugs. So there is a certain element of quality control were created. Not all drugs were reimbursed. There was an approved list in consultation with NTPV created, which fits into the standard of TB care in India, and that drugs were only redeemed through this thing. So every time the chemist need to call and verify and preserve the. So as next steps, all this, the UATBC experience laid the foundation for enhancing the National TB Elimination Program application. So next year version 2.0 had all the private sector applications and the direct benefit system applications. So now the Government of India have incentives both to the patients and the providers. All this are now linked through the Niksha application. So this application enables to pay the doctors for diagnosis and ensuring for right follow-up and also completely.
Great, thank you so much, Shibu. So we don't have much time, but I would like you to please put your questions in the Q&A box, and Shibu can answer via text. Shibu, I would like your thoughts about one issue, which is that the PPIA model was quite complete and had a lot of emphasis on quality. In some of the subsequent work, the emphasis was more just on notification. Can you talk a little bit about why that came about and how we get back to ensuring not just notification, but quality services in the Indian context? Thanks.
So when in fact, actually, when we started the model also, the first battle to win was actually getting the notification in and then slightly elevate the quality. So the mantra of engaging and elevating, the notification was kind of slow hanging. And as you are aware that there is a lot of clinical diagnosis practices are there and prevailing in the private sector. It took a while to actually change the behavior to change into the quality diagnostic practices as per the WHO practices, and as well as the drug prescription practices. So I mean, we are now witnessing that change even in the JEET project, which is a scale up of the PPSA projects, and slight bump in. Wherever there were focused attentions, the bump in notifications are with quality diagnosis are coming up. Especially from a 10%, 12% to now around 20-25% in the intensive effort wards, which also shows, I mean, in selected cities, it goes up to 70% if you look at the TB HIV testing practices. And also now recently we got the vouchers for X-ray with an AA rating approved by Global Fund. I mean, I expect, and also procuring services from the private sector. Including gene experts. So I expect in the coming months, we will be seeing that there will be a bump in the quality diagnosis practices as well. Thank you.
Great, thanks. Back to Amara.
Okay, thank you. So our next presentation is on One Impact, the community-led monitoring of the TB responses for enhanced social accountability. This presentation is given by Kiva Smith of the Community Rights and Gender of the Stop TB Partnership. Kiva has plenty of experience in community rights and gender. Prior to Stop TB Partnership, she worked with the Global Fund on the same issues and working on their strategic initiative. I'll turn it over to you, Kiva.
So good morning or good afternoon, everybody, and thank you to URC and the USAID TB Care 2 project for allowing the Stop TB Partnership to share this platform with you on the future of digital health for ending TB. So my name is Kiva, and I work on a portfolio of work called Community Rights and Gender. And one component of our work which links TB, human rights and innovation is digital community-led monitoring of the TB response, which is the focus of my talk today. I will divide my talk into three. Firstly, I will talk about community-led monitoring, what it is and why it is important, because there tends to be a lot of confusion around community-led monitoring. Then secondly, I will talk about One Impact, which is the Stop TB Partnership digital platform for community-led monitoring. And lastly, I will talk about some of the results of the pilot projects we've supported, lessons learned, and some key steps for us. So now, in terms of the question about what is community monitoring, well, I thought I'd start off by saying what it is not. And so community-led monitoring in TB is not monitoring TB community activities by healthcare workers, and it is not M&E that includes TB-centered indicators. Rather, it is about promoting and protecting the right to health through the empowerment of people affected by TB to know and claim their rights, and the engagement of people affected by TB to design and monitor human rights indicators that they think are important to the TB response for advocacy and action and enhanced accountability. So now to the question as to why it is important. Well, in 2018-19, the Stop TB Partnership, through the strategic initiative to find the missing people with TB, supported 13 countries to conduct what we call the CRG assessment, which is a qualitative study to assess the human rights and gender barriers in the TB response. And cross-cutting findings of the assessment revealed that overall people affected by TB do not know and therefore claim their rights, that duty bearers are unaware of the links between human rights and TB, and that accountability mechanisms to respond to human rights barriers are essentially non-existent. And this is really then where community-led monitoring comes in. So defined as, under the One Impact project, as engaging and empowering people affected by TB to know and claim their rights and report human rights barriers, preventing them from being diagnosed and successfully treated for a rights-based, people-centered, accountable and equitable TB response. It really aims to, on an individual level, to empower people affected by TB to know and claim their rights. And it also aims to generate data on human rights barriers to bolster the TB M&E system for evidence and for evidence-based advocacy at a monitoring, surveillance and advocacy level. And then finally, at a programmatic level, it really aims to evaluate the availability, the accessibility, the acceptability and the equality of TB services, and to inform the design of programmatic interventions and ultimately to overcome barriers to access. So to facilitate community-led monitoring and in alignment with the UN political declaration to deliver innovation, we leverage technology. And together with Jura Technologies and community and civil society partners, we developed the One Impact platform. So it consists of 3 modules, as you can see here. Number 1 is the app for people affected by TB, and it has different components which really allow people to, number 1, access essential information on TB and on their rights, allocate nearest TB care and support services, connect with virtual communities like peer support groups, national, regional and global networks. And it also allows people to set reminders so that when to take medication or to attend certain appointments. And finally, and perhaps most importantly for this discussion today, it allows people to report human rights barriers to access, namely allowing them to engage in community-led monitoring. Then we have the second module, which is the first responder inbox, which speaks to and connects with the app. So as people report the barriers to access, the first responder inbox allows the first responders, which tend to be community health workers, to track and coordinate responses and to record the outcome of those community responses. So in introducing a layer of accountability. And then finally, we have a third module, which speaks essentially to the inbox and links to the inbox, which is what we call the accountability dashboard, which aggregates the community-led monitoring data and records indicators on the usability of the app, the efficiency of the community response, and community-led monitoring data, which in turn then informs community advocacy and programmatic decision making. So in terms of implementation, the implementation of both the intervention and the technology follows the phases recommended by WHO in the Handbook on Digital Technologies for TB. We're following 7 phases, essentially from the feasibility and needs assessment to M&E to scale up. And the process really relies on garnering political will and a multi-sectoral engagement to ensure the uptake of and the use of data. Each phase is also supported by different tools and templates that we have developed to support decision-making processes along the way. In terms of the implementing countries, we are supporting 13 countries who are currently piloting the intervention. Some have completed, and we're doing this under the strategic initiative to find the missing people with TB, and also with working with TB Rep and PASS Centre. You will also see that on the right-hand side, that we are supporting 5 countries to either expand or to take this intervention to scale, either using Global Fund grants or USAID loan agreements, or the Stop TB Partnership Challenge Facility for civil society. So this is really encouraging to see this expansion and uptake and scale up. So in terms of what countries are monitoring, well, they're really monitoring the right to health. So the availability, accessibility, acceptability, and quality of TB care and support services. And essentially what they're asking is, do these services exist and in sufficient quantity? Are they physically, geographically, economically accessible? Are they respectful of medical ethics? And are they scientifically and medically appropriate and convenient? And then in so doing, community-led monitoring will allow community advocates and others such as national TB programs to know in real time data like the actual percentage of people who are engaged in the intervention, who are facing barriers to access, disaggregated and filtered by types of barriers, location, gender, age, and key population for granular detail. Now, in terms of results, I wanted to speak to them on 2 levels. Number 1, how we have enhanced community participation and strengthened community systems, and also how we have managed to address certain human rights data gaps. So in terms of community participation and community system strengthening, we've seen a really important shift. So today, as a result of these discrete projects, over 3,500 people across the 13 countries are engaged in community-led monitoring. In other words, they are engaged in a novel way to support the TB response, which goes beyond the traditional service delivery support that communities provide. Relatedly, over 3,500 people affected by TB now have easy access to information on TB, are connected with virtual communities, and are claiming their rights, all of which is new and novel and in alignment with our global commitments and national commitments to transform the response to be rights-based and people-centered. And furthermore, 13 countries can now generate evidence on human rights barriers to strengthen their advocacy, and national community platforms are either being strengthened or formed to share, discuss, and prioritize community data for advocacy and action, which really was quite unheard of even 3 years ago. So now in terms of human rights data gaps, well, the 13 countries successfully adapted the One Impact digital platform to collect real-time electronic data on human rights barriers to access, which means that 13 countries are now have access to real-time data on human rights barriers to access, which introduces innovation and concretely operationalizes our collective commitments to implement a rights-based approach to TB. Finally, with regards to lessons learned, we learned that using data at a local level was straightforward enough because communities are already informally responding to these barriers. However, what we learned was that using the data at a health systems level was actually trickier. So as such, we adjusted the data to revolve around the right to health, namely the availability, accessibility, acceptability, and quality of TB services, so that the data was more meaningful and usable for the health system. And then from the perspective of people affected by TB, while they agree and appreciate the use of the AAQ framework, they also felt that monitoring freedom from discrimination and the right to confidentiality to capture the broader barriers and needs of people affected by TB is critical. And furthermore, ensuring the rights and protections of populations engaged in the pursuit of community-led monitoring is also an ethical and programmatic imperative, and mitigating those risks to data privacy and security is therefore critical. And then finally, what we heard over and over again was the importance of country ownership of the platform was really, really key. So now in terms of next steps, we're updating the platform, the framework, the implementation guide, and the training module to incorporate lessons learned from the 13 countries. We're also working with Dura Technologies to give countries full ownership and use of the content management system and source code so that they can integrate the platform should they wish into their country data's ecosystems. We're working with Professor Brian Citro, who I believe is also part of this conversation today, to introduce measures to mitigate risks to data privacy, and we're supporting, which we're really excited about, additional countries through Global Fund grants, USAID loan agreements, and also through the Stop TB Partnership Challenge Facility for Civil Society to implement this intervention. So on that note, I will conclude and thank you for your attention and interest in this project, which we hold near and dear to us. And so with that, I will conclude and thank you very much.
Thank you, Kiva. It's really nice to hear that you've taken this as far as it's gotten, and that how people are using the data to enhance and strengthen community participation for the TB response. We do have one question that came in, so I'll go ahead and read that. Can the government deploy the One Impact app? Will that present any conflict of interest if the government is also the one that's delivering the TB services?
So thank you, Donna, for your question. It's a very interesting one. So it is something that we had to consider right from the get-go. And I think what we've learned with regards to CRG in general is the importance of the NTP engagement in the entire, in CRG in order to integrate it properly into the entire TB response. So what we found is that the government played a very sort of critical role in the entire intervention. So while it is and remains a community-driven intervention whereby the community themselves design the indicators, it is really the NTP plays a critical role in terms of refining them and making sure that they align with the priorities of, let's say, the national response, and in such a way that they are able to express their interest in need in collecting this data in order for them to respond. Because at the end of the day, we're collecting this data for a purpose. We're using it for advocacy, and first and foremost for the affected communities. And then secondly, that aggregated data is also extremely helpful and important at a health systems level so that the government themselves can respond to these issues of availability and accessibility and quality of services, which also speaks to the point that I think that Raul made in terms of making sure, wondering whether we can actually see and learn from this intervention and app about the delays in TB diagnosis. And that is one of the issues that we're looking at in terms of the availability of diagnostic services, so that once we get that information, so communities are reporting that under the heading of availability of services. So once that information is collected, then it is up to the government to respond to that. So the community is there to provide a certain service, while the government is also part of the intervention to be able to provide another service, if that makes sense. Thank you.
Great, thank you so much. I think this is a very important topic, and just to note that Thailand is a great case study of how this kind of feedback loop was critical to get real population level buy-in to social health insurance and changes in the health system. So a very critical topic. So I want to introduce Sabyasachi Das, who's currently the head of business development at Day2 Technologies. He's responsible for implementing digital solutions in the public health space and leads engagement initiatives with public health stakeholders. Sabyasachi, please go ahead.
Hello everyone, this is Sabyasachi Das. I represent Day2 Technologies, an organization dedicated to leverage digital innovations for public health and other social sectors. Where COVID-19 crisis has disrupted many of the health services and a lot of outreach work has been affected, we see digital innovations seem to have gained new respect and prominence. Today, we are going to share some of our consolidated learnings from more than 100 plus digital health initiatives being implemented over 40 countries. The presentation will highlight some of the design principles and the implementation framework, what worked, what didn't. To keep it short, we will be highlighting two main approaches or frameworks that we have been extensively using to fight against TB in particular. A lot of these frameworks can be easily adapted to support COVID-19 projects as well, as the process flows are very similar. We have already used some of these platforms for responding to COVID crisis, which we'll be sharing in some of the next slides. The first framework that I wanted to touch upon, which you can see in the current slide, is the individual case monitoring framework. It works on the principle of real-time monitoring of an individual client or beneficiaries through the entire journey from registration to screening to treatment outcome and everything in between. The framework supports multiple channels apart from the smartphone app like USSD, IVRs, which you can see on the left side, and it enables multiple user group, which you can see here. And all these different data that gets collected through different channels gets collated in a comprehensive monitoring and evaluation dashboard. Moving to the next slide, WHO's Prevent TB initiative is a perfect example where the previous framework is put into use. The innovative contact investigation module allows linking contacts with the index cases. The inbuilt business algorithms help monitor a patient through both the TB disease and the TB infection pathways, which is basically the LTBI pathway. The auto-generated alerts at different stages of the journey prompt the healthcare workers to take necessary action on the ground, as well as triggers a lot of follow-up response. The global TB template is now in various stages of implementation in countries like Philippines, Mozambique, India, and many more. The platform has a comprehensive smart configuration setup, which allows the countries to adapt and configure the global template into their own country-specific needs, thus ensuring sustainability and country ownership. A lot of information about this platform could be found on the WHO website itself, or I can share it separately with people who are interested. Moving to the next slide, the power of smart configuration setup that I was referring to earlier is best explained by the COVID Kaya platform, where the component of the TB HIV global templates were adapted to support COVID-19 program within a very, very short period of time, where time is of an essence. We are proud to say that COVID Kaya is now one of the largest digital initiatives taken by WHO Philippines for case monitoring and contact investigation as part of their COVID-19 response. The platform monitors more than 1 million COVID clients through the continuum of care and facilitate contact investigation. The comprehensive dashboard acts as a central repository of data from multiple sources, such as the de novo data generated from the app itself, the historical data that lies in the Excel sheets, the data from other data systems that might exist. The second framework that I would like to touch upon is the community engagement, the civil society framework, or the human rights framework. So what has happened in past is the digital innovations or the initiatives have classically focused on providers rather than making the community as the center of response. However, some of the work we have been doing with partners like Stop TB Partnership, UNAIDS, AMREF, and many others, we have been able to establish a model where the patient communities can become the center of response through direct access to information, connecting with other community members through innovative chats and forums, getting access to nearby health facilities, and more importantly, voicing their opinions and requesting civil society engagement and response, thus bringing accountability and strengthening the country advocacy process. Moving to the next slide. So One Impact platform developed in collaboration with Stop TB Partnership is a perfect example of the previous framework I was talking about. It's a community engagement and a human right framework put into use. We already heard about One Impact from our friend Kiva from Stop TB Partnership, so I won't go into too much details here. Currently, One Impact platform is being rolled out in more than 10 countries supporting multiple TB communities. Once we have built these capacity within the communities and the digital ecosystem is available on the ground, this can be quickly leveraged to support high-risk groups impacted by the crisis situation such as COVID crisis. One Impact is a good example where this platform was quickly adapted to also address needs of TB communities affected by COVID-19. Moving to the next slide. Needless to mention, one of the key aspects of all these different approaches are to leverage data in real time for evidence-based decision-making, advocacy, and on-the-ground response. Our comprehensive analytical dashboard and ETL tools does just that. So these are some of the technical and design considerations that are listed here. The platform is built on DHIS2, like you can see, which makes it very sustainable, especially when we talk about countries who are on DHIS2. It's open source technology, which allows the countries to completely own the platform and manage it by themselves. The smart configuration setup, which we talked about earlier, allows the countries to make any kind of ongoing changes by themselves in a self-use mode. Since we have also been working a lot with the TB and HIV program, data privacy is very, very crucial. So we are compliant with a lot of the global data privacy standards like FHIR, HIPAA compliance, GDPR, and others. The platform is also future-proofed, so it's multiple channel where we're using channels like USSD, IVRS, apart from the smart phone app. Not just that, we have integrated with social media channels like Facebook, WhatsApp, and others. It's future-proof in a sense that we are using cutting-edge technologies like blockchain, artificial intelligence. We also integrated with third-party payment gateways like M-Pesa and others. And overall, to make it sustainable, we have open APIs, which allows us to integrate with the country's existing data ecosystem. So the platform works on the principle of harnessing best practices from other project implementations and an attempt to eliminate duplications of effort. The slide describes how the global template for any program can be scaled up from one country to another, and similarly, it can be also extended from one program to another. Additionally, the smart configuration setup allows countries and implementing partners to manage and adapt the global template based on their evolving needs, such as the form creation, workflow adaptation, content management, facility management, user management, indicator management, and language configuration, and many more. Apart from bringing a robust technology and design thinking process, we have been able to develop a strong implementation science to successfully execute some of these digital framework on the ground. This ranges from our assessment guideline and templates to country adaptation frameworks, training packages, data use, and overall M&E strategies that goes along with the technology. So that brings us to our thank you slide. So thank you very much, and we are very happy to respond to any question. In case we are not able to cover everything today, please do feel free to contact me directly. My coordinates are given below on the slide. Thank you so much.
Great, thank you so much, Sabyasachi. So again, there are some questions in the Q&A box for you to respond to by text. But if you could briefly talk about one other aspect, which is we can have beautiful tools that are intuitive and nicely designed and integrated with DHIS2, etc. But there's always this question of user uptake. Do you have any kind of behavioral learnings on the best way to get broader user uptake of these kind of tools? Thanks. We don't hear you yet.
Can you hear us? Can you hear me now?
Yes, thank you.
Great. So I was saying that one of the key factors that we have seen working in terms of the user uptake is really multiple stakeholders coming together and they all being on the same page. So for example, one of the approach that we have taken in making this solution work is really integrating different stakeholders work. Like one hand, we have the provider-centric applications. The other side, we are working like platforms like One Impact, which you heard from Kiva as well, which deals with the community, and how these two systems and these two user group really talks with each other makes a lot of difference. And I think also technically making sure that eventually these platforms are completely owned by the countries makes a huge difference as well. So the fact that we have built our solutions around DHIS2, and we have a lot of open APIs to sort of integrate with the existing data ecosystem so that the platform coexist in the country's existing data ecosystem.
Great, thank you so much. And again, there are other questions in the chat if you are able to respond in text. Thank you to all the presenters for this very interesting session. Thank you to my co-facilitator Amara, and back over to TBCare2. Thanks.
Great, thank you very much. Thanks to both of our moderators and for all of the speakers for this set of presentations. Certainly an interesting cross-section of all of the different innovations happening in the private sector. So our next presentation session focuses on data analysis and data analytics and their importance to ending TB. I'll be co-moderating this session with Dr. Zami Temesgen from Mayo Clinic Center for Tuberculosis here in the US. So we do have an exciting set of presentations in this session. We're going to talk about mapping, modeling, machine learning, and the importance of data privacy and security in the context of an increasingly data-reliant world. So it's definitely an interesting cross-section of topics in this session, and we have a lot to cover. So without further ado, I would like to introduce the first presentation, which will be given by Vincent Murens from EPCON in South Africa. We're presenting on epidemic control and mapping. So we can go ahead with the first presentation here.
Welcome, everybody. My name is Vincent, and I'll give an introduction into the epidemic control platform as developed by EPCON. About 4 years ago, we received a TB mapping assignment in Southern Africa covering 10 countries. And the primary objective was to identify hotspot areas and communities at risk of developing TB. Now, during this project, we realized things had to be managed differently if we are to end TB overall. Data is sparse, context is missing, and systems are not dynamic in nature. And this is not a TB problem alone. So we've learned that today, many countries in the world have issues managing their health data, if you look at COVID, and a lot of systems in place for managing these epidemics and providing output to set up interventions on the ground. So we decided to take action on that. So about 4 years ago, when we realized that, and we brought together a team of GS experts, data scientists, and medical experts to develop an adaptive AI-driven engine for analyzing program data in a local context. And the core objective is to estimate TB burden at the highest possible resolution and provide output that matters for finding missing patients. So today the platform uses real-world data like climate, population density, demographics, air pollution, all of that combined with health records and programmatic data. It trains a causal inference model to provide output relevant to TB detection and control. And that output gets then visualized through dashboards for more in-depth analysis, and a user-friendly geoportal provides actionable output to stakeholders involved in the program. As a standard for assessing that programmatic data, we've used since the beginning the MATCH framework as developed by the Kid World Tropical Institute in Amsterdam as a reference to generate output for location-aware tailored interventions in function of risk, capacity, and yield. The first project was implemented in Pakistan, and we did that using the immediate support of KIT Royal Tropical Institute. So we operate also in close collaboration with the National TB Program and Mercy Corp as a help partner. The scope of that project was really to pull programmatic data from country systems, provide real-time reporting on the program progress, and upgrade that reference material using environmental context. And so the ultimate aim is to provide a predictive model for the full country. And so the project covers all regions of Pakistan, but it's essentially focused on the intervention areas of Mercy Corp. So there we provide more granularity. And so the full region, or actually the full country, offers the NTP a tool as well to enter into conversation with health partners on the ground, because they can actually look at the potential risks across the region and then jointly define interventions on the ground. So what you see below on the left corner is a location where TB care cascades, and that's provided in real time. And so on the right, you find predictions at subnational level. The scale of them are arbitrary, and values are pushed. I'm sorry for that. Values are pushed for relevant locations and communities or chest camps using a user-friendly geoportal. The success of the program is highly dependent on the buy-in from local government organizations. We have fully opted for a co-creation process whereby dedicated enthusiast teams enable the success of the program. So it's really an all-inclusive co-creation process that we generated, and everybody has a buy-in and also has a strong contribution to what should happen. The health partners are crucial because they are actually using the data to execute upon these tailored interventions. And so that's very critical, and they can provide the evidence as well on the ground as interventions are taking place. And this level sometimes might be conflicting because obviously there are different health partners active in the country. They don't always want to share the data as well, with the national level, especially the programmatic data. So, it's really important for us as an organization to be very open about it and provide value for everybody involved. And that can really engage the various parties to contribute. Important to note as well is that from a budget perspective, the willingness to implement the model in view of improving public health by far outreach the monetary aspects of the projects. And so this goes for all parties involved. And support is provided in the form of expertise, IT, knowledge, local networks, M&E, and data science. And then public sources have been used to enrich the programmatic data. And so there we collaborate with partners on the ground. Again, I apologize for that. So we collaborate with partners on the ground, but we also have a lot of public data available, like the global forecasting system, human development index, World Pop, high resolution demographics, and so forth. So all of that is really used to enrich the platform and to learn from, for then enabling the predictive model to do its work. The impact is focused on the ability to identify most hit and underserved regions for countrywide program planning. And then secondly, as well, provide local context to help partners for effective intervention planning and finding these missing patients. And so we provide predictive values, number needed to screen, communities at risk, and other indicators. And the platform learns through an unsupervised Bayesian model providing causality. And that allows us to identify unknown unknowns, so hidden variables that might have a high contribution to development of the disease. And that allows one to really attack the problem as well from its roots. So from a historical learnings perspective, the probabilistic model propagates what might happen in regions where known variables are present and will incrementally learn to calibrate its earlier findings as evidence becomes available. And so as health partners are using the data and they generate, are using, the tools to plan the interventions, they will generate evidence on the ground, and that again feeds into the platform and allows us to actually validate and potentially calibrate as well. And all of that happens in real time at population, community, or the individual level, allowing for immediate action. And so the platform can distribute this intelligence to the edge and thus operate and reason in an offline mode as well for remote areas. And that's especially important also. I apologize again. In view of capacity, catchment areas are identified, and then risk within these are quantified and displayed geographically. So to finish, the Pakistan project is implemented and being fine-tuned as we speak. And as new data becomes available, we continue to increase its complexity and to provide better output. And in addition, the team will also start working with a newly developed electronic case-based surveillance tool. And that really provides us much more quality, data quality, and also will automate the screening process and as good as possible. And so that combined within the predictive values will really help us to reach those final objectives. In future as well, we plan to add comorbidity. So COVID will play a very important role. We have also a pilot in Europe at the moment for COVID. And so obviously we will look at combining these different models so that we can have comorbidities, and then especially from a causal inference capacity that will provide hopefully very useful output. And that will also allow us to generate, apologize again, simulations and early warnings. So that is really also the next step. And so the platform really tells you what's happening, when, where, and who might be mostly affected. So thank you very much for listening, and we'll be happy to answer any questions that you may have during the rest of the session.
Great, thanks so much for this presentation. I think it's especially interesting to see using the sort of like subnational estimate. So I don't know if we have any questions coming through at this point. People are welcome to ask them, but I would really be interested from my side to hear about the data sources and the sort of ability to use subnational estimates to rather produce them and then also to use them, and how that sort of, I realize it's probably very different, and even more differences with subnational data when you look at different contexts, but sort of the challenges and the possible solutions to those challenges that you may have in mind as far as the requisite data for looking at subnational estimates. If you could talk about that, I feel like that would be really an interesting discussion.
Okay, good afternoon or good morning, everybody. Also, thank you again for the opportunity. With respect to the question, as we've seen in the previous presentations as well, there's obviously a lot of attention that goes into establishing those systems that are capable of generating that local data. And so also in Pakistan, obviously, was not an exception, I guess, to many of the other countries, that the availability of trustworthy tools that allow, let's say, health partners on the ground to screen individuals is definitely a challenge. So if the systems are there, they're often, operating in a disconnected mode, and aggregated numbers or disaggregated numbers, for that matter, are being published and consolidated at the national level. But getting really your hands on the the data that gets generated by health partners is a big challenge. And so part of the exercise, or actually a large part of the exercise, is assisting as well the health partner in generating and analyzing that data. So by using the information, we also immediately provide indicators as to how reliable the information is. And so that's an important one, because that then helps, both the NTP and the partner to learn, where potentially some of those gaps might appear, and where the data quality might not be optimal. So it's definitely a big challenge and part of the exercise of going there. So far in Pakistan, our experience has been very good as well in the way we operate and collaborate with the teams. In other regions, it's and we are a relatively young company, so it's not that we have too many regions to cover. But in other regions as well, that still is a challenge that we are faced with as well during the implementation of the project. So it's definitely something that is critical. And as mentioned before as well, I think important that is really not a TB issue. And so we face that, if you look at COVID as well, all across the globe actually, and in Europe where we are operating on the pilot, it's a challenge that even the more advanced countries are facing with. So, and as a matter of fact, they might be less prepared as well, because many of the regions that we are operating with TB, they've been fighting these challenges all along, and so they're often more prepared than some of the countries in Europe or North America.
Certainly. Great. Well, thank you so much, and thanks for being here today. With that, I'll move on to our second presentation in this session, which will be given by Chris Masek from System 1. Chris will present on connecting services across the TB cascade of care. So we can go ahead and start this presentation.
Good morning, good evening, or good afternoon. My name is Chris Masek, and I'm the CEO of System 1. I want to talk to you about connecting services across the cascade of care and what data makes a difference. We can divide the cascade of care into two large areas: case finding and treatment. In the center of this cascade of care is diagnosis. It basically separates the case finding from the treatment, and it's the pivotal, I would argue, the pivotal piece of data when looking at the cascade of care. All case finding culminates with confirmed diagnosis. That's the objective, to find people who have TB. And then all treatment begins and is adjusted based on diagnosis. So diagnosis is that central point, that moment where we shift from finding to treating. And if you start with that piece of data, then you can look either downstream in the cascade or upstream to the case finding, and you can start to measure the effectiveness of either of those systems from that moment of diagnosis. At System 1, as the makers of GX Alert, we've been doing just this. We've been focused on diagnosis in countries all around the world. So for 7 years in 45 countries, we've connected over 3,500 gene expert instruments, and we've connected over 10 million PCR results for TB. I talk about diagnostic connectivity, and that's being when we connect all of the lab instruments to a central server so that the results of all the TB testing are going into a central platform in real time. I talk about that connectivity as a way of basically turning on the lights, as providing transparency into the diagnostic lab network. And when you provide that kind of transparency, when you can illuminate your diagnostic network in that way, you start to see a number of things. And there's all kinds of data that we get from that. There's two main kinds, and I usually break that up into operational data and clinical data. And for the purposes of this talk, I want to focus on the clinical data for a moment. And when we talk about finding and treating people with TB, the clinical data is really what matters, and finding those who are tested positive for TB or drug-resistant TB. And connectivity can provide that kind of real-time pulse on your diagnosis and your diagnostic network. And that's important. Once you have that set up, then you can monitor how many people and who are being diagnosed in your country with TB. There's sometimes confusion about what's required for a connectivity solution. There's a number of different vendors out there in the market. There's a number of different systems. But I've tried to break it down into a few things here. Basically, you need the leadership from the top level. The NTP or the MOH needs to lead the effort nationally. And then you need buy-in from the states and other implementing partners to work with the systems at the local level and report on. In terms of staffing, as a rule of thumb, I would say for every 100 gene experts you've got in your network, you need a quarter of a full-time person. So example, a country with 400 gene experts would probably need one full-time person managing that connectivity. And you just need one capable person. You don't need an actual engineer. You just need someone intelligent with some basic training and experience. A technical person is helpful, but again, they don't have to be an engineer or a rocket scientist. In terms of costs, what we've seen is about $1 per test or $1,000 per gene expert a year, something like that. And that cost includes all of the equipment, the routers, the modems, the data costs for bandwidth, the SMS costs for messaging, the human resources and system integration. And this varies depending upon the scale of the network and the country and the efficiency of the program. In terms of equipment, you'll need modems, you'll need SIM cards, you'll need web servers, either a cloud server or an actual physical server. You need some kind of SMS gateway if you're sending SMS messages or emails. And then finally, you'll need some kind of information system that's capable of managing the diagnostic lab results. So a system that can receive all of the test results and then capture whether those have been linked to treatment or other things, be able to integrate and communicate with the patient record systems, the case management systems, adherence systems, those other things. By anchoring on diagnosis as the data that you measure across the cascade of care, not only can you measure upstream for case finding and screening, chest x-rays and presumptive case efforts, but you can also measure downstream from diagnosis to treatment, adherence, and outcomes. One of the things that immediately becomes apparent if you do that is the gap between diagnosis and treatment. And this is typically called the pre-treatment loss to follow-up. It's the number of people, or the percentage of people, that have been diagnosed with TB in this case, but have never made it to treatment, are not in a treatment register or receiving treatment. That number can be as high as 18% on average in Africa, 13% in Asia. And if that's 1 in 6 people that are infected that you've diagnosed already, you've already gone to all the effort to find them and diagnose them and not treat them, it's a huge opportunity in terms of number of people infected, number of people that are sick, number of people that are walking around not being cured, not being treated. And that number falls right out of this approach. So to summarize, I'm suggesting that diagnosis is the central piece of data in the cascade of care. I mean, of course, there are many pieces of data and there are many things that you can and should and will and do track. But diagnosis really lets you look at the effectiveness of your finding efforts as well as your treatment efforts. And it points out that pre-treatment loss to follow-up, which is a huge gap that we can begin to reduce and get more people who are diagnosed onto treatment and follow up with them. To summarize here, what I think the next steps for countries are is to help those countries digitize and centralize all their test results. And that really falls right out of connectivity. If you can connect the diagnostic networks, it digitally captures those test results, which can then be reported back to patients and healthcare workers in real time. The second step is for tracking those positive TB and DRTB cases and finding some way within your health system, within your treatment systems, to confirm that the positive diagnoses have been linked to appropriate treatment. And again, I say confirm this, but I mean record it, so that for every positive test result you have, you can know whether that person, that case, has been put on treatment or not. And for the ones that have not yet been confirmed, that's where you focus your follow-up. In this case, in that graph, that would be the 30% that have not yet been linked to treatment. And that 30% are a known set of test results. We have those patients' names, we have their phone numbers in many cases, their addresses, we have their diagnosis as a positive for TB, a PCR confirmed positive diagnosis. They're the ones that you should track down. By doing that, you can then, step 3 here, measure the pre-treatment loss to follow-up. You're basically measuring the effectiveness of your system at finding and treating people. Finding being defined by that confirmed positive diagnosis, and treatment being someone in your treatment register, someone on treatment, that you're now measuring adherence and outcomes with. For the ones that are not on treatment or not confirmed, that's your pre-treatment loss to follow-up. That's the 30% in red here, that this system or this approach will help local healthcare workers and supervisors and district area and state level people to put attention and resources on that 30% to make sure people aren't falling through the cracks, to make sure people that are diagnosed and are positive with TB or drug-resistant TB are ending up on treatment. That's all I have for my talk today. Thank you very much.
Great. So I think we have maybe more of a comment about digitizing expert results and why it was not done 10 years ago. And, would love to hear your thoughts on that. I also, from my side, I think sort of looking at this classic, test and treat strategy and having that central piece of data being, of course, the diagnosis and bridging the gap between testing and treatment. So I wonder sort of what are the, this is a classic problem. So what are the strategies within GX Alert or within digitizing these results for saying, how do we operationalize this tracking and how do we streamline that with this digitization, and sort of what are the challenges within that solution to this larger challenge of bridging the gap between testing and treating?
Hi, I would say the biggest challenge is that many countries have a database, even if they connect their GeneXpert or their other diagnostic networks, they then end up with a database of test results, and then they have a database, a separate system for case management or electronic medical records for patients on treatment. And unfortunately, in most countries, those are two distinct databases that they cannot reconcile. And so the number of test results is typically significantly larger than the number of people on treatment. Part of that is accounted for by the fact that some people are tested multiple times and in multiple areas. So there's some duplication in the testing database. But the biggest problem is that there's not usually a unique identifier so that a computer can reconcile those two data sets. We do work with countries and we have developed different techniques to help generate a unique identifier and to communicate with some of the patient record systems when we report results automatically. Having some kind of ID on the sample, or for the presumptive case, we integrate with chest x-ray systems or other screening systems so that when they find a suspect or a presumptive case, they can register it with our system when they refer for GeneXpert testing. And then again, when we get the result, we can map it back to that screening effort. But all of that requires a little bit of thinking and a little bit of coordinating integration with the system. And typically, we don't see that happen in countries in terms of coordinating the treatment database with the diagnostic database.
Great, yeah, thank you. And I think that starts to get at this larger question here in the Q&A is, why was this not done 10 years ago? What are the data sort of interoperability and the sort of connection between databases? But aside from this, what are some other, very briefly, sort of high-level challenges that exist in digitizing these results and delivery and communication of results?
Yeah, I think, and some of the questions are pointing this out, that there's also questions about using the GeneXpert network optimally, and if the machines are down, if there's service issues or stock out issues. So, in my presentation, I mentioned two kinds of data, the operational data and the clinical data. So I think countries are getting a better handle. I know donors are putting some attention and effort toward optimizing the diagnostic networks, and this gives better visibility into operations, into service, into stockouts, all of that sort of thing. So I know there's efforts that are automating that and making that easier and more functional from the operations side. Once those kind of questions are resolved and you have a fairly reliable connectivity on top of a reliable diagnostic network, then it's questions about how to integrate those results into the rest of the health system, how to report back to patients, how to report back to clinics and facilities that have sent out for the testing. And all of this, again, can be done, but it requires a little bit of thinking on the part of national TB programs and local implementing partners, how to coordinate those services and those systems. And again, we're talking across the cascade of care. And again, my position is, if you can start with the diagnosis, because that's a kind of definite, digital, almost irrefutable fact. And again, once you set up your connectivity, it's a fairly easy lift to monitor that on a daily, weekly, monthly basis, what the test results are saying. Then you start from there and make sure you're pushing into your treatment systems effectively, and that you've got ideally 100% match between all of your diagnoses and all of your people on treatment. And of course, that's the goal, and that would be 0% pre-treatment loss to follow-up. But it's hard to attain that goal. But once you start measuring it, then you can see where the challenges are, which either parts of your country or which parts of your system are having bottlenecks or not reporting reliably, so that all of these things can be measured and connected and followed through.
Great, thank you. And I know my co-moderator, Dr. Temeskin, has a question here or a comment, so I will pass it over to him. So thank you so much. And I think, Dr. Temeskin, if you have anything to add before we move to the next presentation.
Sure. Chris, a wonderful presentation. Thank you. The linkage to treatment is just the beginning of a long and arduous journey for patients with tuberculosis. How about the rest of it, which you haven't mentioned? How do we capture that, the retention and treatment and the ultimate clinical outcome? How is that connectivity maintained and documented?
With our systems, we've kind of oriented them toward somewhat of an M&E function. It's that ability to look across the cascade of care to see that the high-level characteristics of treatment or characteristics of a patient's journey through that system are being met. So once we find a positive confirmed case and we start pushing into the treatment system, the first thing that we record is whether there has been treatment initiated, whether there has been appropriate follow-up. And again, that varies whether it's a drug-resistant TB case or a drug-susceptible TB case. But we can also tie into adherence, for instance, and just get a high-level marker on whether the adherence is happening or how successful that is over the course of treatment, and then eventually what the outcome is. So we're looking to provide, again, downstream from the moment of diagnosis, the other high-level features and ultimately the outcome of treatment for that particular patient who is diagnosed.
So you do capture those?
Yes, we do.
Okay, thank you.
Thank you all.
Okay, greetings everyone. I guess we will continue with our session. I'm Zami Temeskin, Director of the Mayo Clinic Center for Tuberculosis, a World Health Organization collaborating center in digital health and precision medicine for tuberculosis. It is my pleasure now to introduce the next speaker, Brian Citro, who is an assistant clinical professor of law at Northwestern Pritzker School of Law in Chicago, the United States. He is also a technical consultant for the Stop TB Partnership and the UNDP HIV Health and Development Group. The title of the presentation is Data Privacy and Security and the Opportunity Cost of Digital Health Technologies for TB. Brian?
Thank you. So it's a pleasure to be here, to be a part of this. And I want to thank Sharyana and Hala in particular for taking the time to speak with me a couple weeks ago and to see how this presentation might fit in to the two-day event. And so I'm not quite sure I think this is the best session, although I think it's clear from the title and what I'll be talking about that it's, in some ways it's a little ill-fitting. And I think that may be indicative of a larger point and concern, which is the foundation of this talk, which is in essence, with all the movement and progress toward digitizing health and for TB in particular, but also with COVID in mind, are we doing enough and are we aware enough about concerns for privacy and security, for data privacy and security? And so that's what I'll be talking about today. And I'll also be throwing in another concern that I have around digital health technologies and digital adherence technologies for TB in particular, and that's the opportunity cost. So as the first bullet point here says, the price of collecting sensitive information is the cost of safeguarding it. So I think this is kind of a nice platitude, I think, that speaks to the balance and the responsibility for any effort, intervention, or technology that collects information that is sensitive, whether it's personally identifiable information or other sensitive information, that as soon as that's happening, there is a cost or a corresponding duty to safeguard that information. So that's kind of a high level point. Now, ensuring data privacy and security is also a requisite element to realizing the actual promise of digital technologies for TB. And I'll talk a little bit about that later, but I mean, the point here is this is not just a nuisance and shouldn't be an afterthought. Safeguarding and being fully aware of the challenges and how to ensure data privacy and security is a fundamental part of what it means to successfully use digital technologies. And I'll give some more thoughts on that in a second. So we can go to the next point. This is about the opportunity cost. So technological progress should not be conflated with real progress in improving TB treatment. And the point here, which I'll get into in a few minutes, is really around digital adherence technologies and what that means for the continued global dominance of directly observed therapy. And is there an opportunity cost with regard to the resources that are being put toward digital technologies? So first, though, data privacy and security for digital TB technology. So the little Venn diagram here illustrates a general way that people think about data privacy and security, which is that it's an overlap. There are concerns about privacy on the one hand, and there are concerns about security of data. And it's that overlap in the Venn diagram where we get digital, or rather data privacy and security. So there are three reasons why all of you and anyone else who is working around digital technologies in health, there are three reasons why you should care about data privacy and security. First, it's the law. and so there's a complex and recently increasing proliferation of laws that regulate, in particular, health data. So if you're not thinking about that, there's a good chance that you are unintentionally or without your knowledge violating the law, or at the very least implicating the law. There are laws that protect people from government use of their data. There are consumer laws that protect consumers that are very broad, that probably apply to any kind of an app that's being used. And then there are just broad-based digital data laws that are popping up literally every day around the world that would apply to almost every intervention that I have heard talked about and that I've seen on the agenda here. So it's the law. Second, if we're truly concerned and committed to protecting and promoting human rights, we have to care about data privacy and security. The right to privacy. So regardless of whether there is a law that says we need to keep information private in terms of someone's status as a TB patient, there's a right to keep that information private. And why do we care about that, aside from some normative concern of privacy? Because it's a highly stigmatized disease. If we don't keep information private, if we're not careful, people experience discrimination. That in turn is a problem in and of itself, but it's extremely counterproductive. So the last presentation was talking about pretreatment loss to follow-up. While there are certainly structural and systemic reasons why people get diagnosed and then don't go to treatment or don't get to start treatment, there are also serious social concerns, economic concerns that are closely associated with stigma and discrimination that people experience every day as they deal with TB. So protecting and promoting human rights is critical to the TB response, and data privacy and security is a part of that. Finally, if we want the programs and interventions we're doing to be successful, and we want to achieve the health outcomes that we're aiming for with these technologies, we have to protect privacy and security. So this is a fundamental concern. If we don't build the trust of the community that we're, for whom the intervention is trying to help, there will be chilling effects. If one person experiences their data, a breach in the data, and somehow they're negatively harmed, other people are not going to want to be part of that intervention. And then there's political liability. So separate and aside from whether the law has been violated, how does the government, the NTP, the Ministry of Health, how do they respond when they see a digital intervention that is causing harm in the community? So this third area, the reason is basically to say that if you don't protect digital privacy and security, the very objectives of the programs, both in terms of the programs themselves and the health outcomes, are at risk. We can go to the next slide. So what is this opportunity cost? So watch out for that Trojan horse. So the metaphor is that the Trojan horse looks like one thing, but it turns out to be another. So when we're talking about digital adherence technologies for TB in particular, is it something different? You can put on, please, all the bullet points here. So some of you or all of you may be familiar with these, but there's meta-analyses and systematic reviews of randomized controlled trials and other studies that seriously call into question whether directly observed therapy is effective compared to self-administered therapy. And they indicate that there are serious social and economic barriers, or rather DOT raises these barriers for people. And they're barriers to things like pre-treatment loss to follow-up or just treatment adherence more broadly. So there's a growing global concern or kind of willingness to question the dominance of DOT, but DAT perpetuates that. So DOT's global dominance deprioritizes other treatment approaches. That's the opportunity cost. So, and I realize it's not a zero-sum game that we're involved in, but we have finite resources. Are we using those resources to intentionally or unintentionally promote and perpetuate the dominance of a system, of a paradigm, a treatment paradigm, that is maybe not the most effective paradigm? Are we even considering other approaches, shorter regimes, for instance? The arduous, long journey that was mentioned in the question before my speech about in terms of what do you gather data during the treatment period, 6 to 8 months. So doesn't need to be that long. Are we putting the right resources into making that treatment regime less arduous? Are we promoting treatment literacy, individual agency, full and accurate information? So these are just components of what self-administered therapy or something that isn't DOT would look like. Are we looking to how people living with HIV live the rest of their lives taking their medicines every day and someone's not watching them? So the opportunity cost, again, is whether the focus on digital adherence technologies is drawing resources and intellectual focus from an alternative to DOT. And that's it. Thank you again for having me today.
Thank you very much, Brian. A very, very interesting and instructive presentation. May I ask you a question about the last point you made, which is how the directly observed therapy distracts from other priorities. And if you can elaborate on that, because whether a treatment duration is short or long, adherence is an important component of it. And how does the use of technology to enhance or support or promote adherence, how does that affect the whether a treatment should be short or whether we should promote treatment literacy or things like that? If you can just clarify that a little bit.
Sure, that's a good question, and I appreciate the question. So the premise of the question is a little bit incorrect, which is to say, my point is that if we're promoting digital ways to observe, which is to say digital adherence technologies, many like wirelessly observed therapy, WATS, for example, they're just digital ways to do the O in DOT. And my point is, to the extent that we're putting resources into those technologies, whether it's intentional or not, we're perpetuating DOT, right? And so, of course, adherence will always be important. It's not only TB, by the way, for which adherence and treatment is important, but TB is the only disease for which DOT, or observed therapy, has been dominant for so long and remains the primary treatment paradigm. So my point isn't that digital technologies can help, or that we shouldn't try and use them to help people adhere to treatment. That's perfectly fine. My concern is when doing so perpetuates without thinking the whole paradigm of DOT. And so if we have a shorter regime, treatment regime, it becomes easier to adhere to, unless the side effects are worse for some reason, just because you're doing less, you're taking medicines for a shorter period of time. So I'm not suggesting it's a zero-sum game, but what I am suggesting is that there are lots of different ways to improve the way we treat people with TB. One of those would be to seriously consider an alternative paradigm from DOT. And my concern is that the focus on digital technologies that just help us do the O in DOT, that they are creating an opportunity cost, because resources and intellectual curiosity could be put toward reimagining TB treatment more broadly.
Very good, thank you. So I see here a question that states the downside of directly observed therapy has very often to do with the cost of travel, and something like a video observed therapy becomes with video observed therapy, then the cost of travel and the inconvenience of travel becomes less of an issue. How do we manage this under circumstances imposed by COVID? And I don't know if that is a question to you, but you can attempt to answer that. Yeah.
No, that's a good question. I would say it's more of a constructive comment. So, and because I didn't have a lot of time to talk, one of the points I would make is that on the margins, we certainly could see, and probably are seeing to the extent that these have been implemented. On the margins, we might see improvements around or reductions of some of the burdens that DOT causes. Obviously, health or facility-based DOT compared to WAT is going to cause more burdens in terms of getting somewhere, right? With the cost of getting somewhere, the difficulty of doing it. So yes, that is an improvement. And in some ways, you might say, well, there's a huge privacy improvement. And I would agree with that, because the physical infrastructure that we have for TB reveals someone with TB the moment they walk into a clinic with a neon sign flashing TB. That's how clinics basically look all over the world, which is another separate concern. So yeah, if you can do something from the comfort of your home, it reduces privacy and it reduces some of the burden around travel, which also now includes concern around COVID. So I absolutely agree with that, and think that that's an important part or benefit of DAT, but that also entrenches the opportunity cost, which is to say, if we think that that's enough and that those kind of on the margins improvements in DOT is enough, I think we're making a mistake, that we're not taking the opportunity to completely reimagine DOT in the first place. And so that would be my response to that.
Thank you very much, Brian. You've raised very important points, and I hope that we continue to discuss these points going forward, but I don't have any additional questions posted for you in the chat forum. So thanks again, Brian, and I will proceed then to introduce the next speaker. Our next presenter is Erez Yoeli, a research scientist at MIT, where he directs the Applied Cooperation team. His research focuses on altruism, understanding how it works and how to promote it. He collaborates with governments, nonprofits, and companies to apply the lessons of this research towards addressing real-world challenges like increasing energy conservation, improving antibiotic adherence, reducing smoking in public places, and promoting philanthropy. The title of the presentation is AI-enabled differentiated care models for decision support and personalized public health. Erez?
Hi, I'm Erez. I'm a research scientist at MIT. This is a collaboration with Kahila. That's a digital health startup that is trying to build platforms to support tuberculosis patients. And two machine learning researchers, Jonas Jonasson and Justin Boutillier. The goal of the project today is to tell you about how we're trying to incorporate machine learning into Kahila to provide better care, and in particular to provide care that's more differentiated. Our goals here are twofold. We're trying to provide care that's better, more compelling, and really to reach out to the folks who need it most when they need it most. And also to save costs a bit, to prioritize resources so that we're not reaching out to the folks who don't need that. And instead saving ourselves the time and effort, and also saving those patients the effort of interacting with us when they don't really need that. So those are our two goals. Kahila, just a little bit of background on it. If you want to know more, then check out my other talk at this conference, because I'm going to mostly focus on the machine learning piece here. But Kahila is a USSD platform. That means it works on dumb phones, that reminds patients to take their medication every day, requests a verification. So it's a two-way SMS platform. If it fails to receive one, it requests another. If it fails to receive one, it requests another. And then if it still fails to receive a verification after 3 attempts, then there's a team of supporters that tries to reach out to patients and get them back on the wagon, make sure that they are continuing to adhere. There's some additional features of this platform. The key thing you need to know is that these features were designed with a lot of behavioral science in mind. And the other thing that you need to know is that we've tested this platform in the past in an RCT in Nairobi. Back in 2016, it took about a year to run the RCT, and the data that I'm about to use in this discussion today comes from that RCT. That RCT was fairly successful. In that RCT, we managed to reduce the number of people who didn't complete treatment from about 13% to about 4.3%. And the key data available to us from the RCT are the patient characteristics and treatment outcomes that are being pulled from the TB registers. It's data you're probably familiar with. There's also an additional source of data that we're able to use, and that's people's behavior on the platform. And the key data there is whether they verify on a given day, but there's also some additional data that we'll be able to use. The question is, can we build machine learning algorithms using these data that are useful for intervention design? The question we'd like to ask if we're designing an intervention is the one you see in front of you. Can we anticipate which users will benefit from support the most on a given day? And that will allow us to do the two things that I told you about at the very beginning, to provide better support and to prioritize resources. This question seems easy enough to answer, but it actually, if you think about it, it has a lot of different components. And today I'll only be able to talk about some of these because of the limited amount of time. But I'm happy to discuss any part of this with you guys offline. So in front of you, you see some of the questions that I think are built into the big question at the top. You want to know which users need support. In other words, which ones are the ones who would fail to complete treatment, and which ones are ones who, even if you didn't do anything, who would actually successfully complete treatment. That's one key thing that you would like to know in order to figure out who will benefit from support. Another one is, who's going to stop verifying today? If this person is going to stop verifying, that suggests this person might not be taking their medication, and that person might need support today. If they're going to continue to verify, then they probably don't need support on that given day. So can we predict that? And then the third one is who's going to respond positively to engagement? Who is going to start verifying again if we engage with them. So those are the three questions we would like to know. And today, I'm only really going to have time to talk about these two here. Are people at risk of a poor treatment outcome? Are we able to identify those who are at risk of a poor treatment outcome? And are we able to identify those who are likely to cease verifying? And if we can, that means those are exactly people we should at least try to engage. So it's telling us some of the key things we need in order to build that intervention and reach out just to the folks who really need it. The way we do this is we build predictors that on a given day, we call these rolling horizon predictors, on a given day, take the data available to them at that day, none of the data that's coming in the future, because you couldn't use that in practice, right? You can only use the data that's available to them on the given day and try to predict these two key outcomes, whether somebody will fail to complete treatment and whether somebody will not verify the next day. That predictor uses the features that you see in front of you. There's some static features that most of which came from the TB registers, and there are things like gender, HIV co-infection, et cetera. Then there's some dynamic features that we build that differ from day to day, and we build from patients' behavior on the platform. Things like how many times have they verified in the last 7 days, how many times have they verified in general, how much time do they spend on the platform, et cetera. Our goal is to take this predictor and then see, does this predictor that we build of these two key outcomes that we've been discussing, does the predictor actually do better than a coin flip? If it does, we can depend on it in order to build our intervention. And if it doesn't, then maybe we shouldn't depend on it, right? So that's what this next slide is going to evaluate. What you see in front of you is the performance of predictors on different days of the RCT. Day 0, day 10, day 60, day 120, day 180. Remember, those predictors are only using the data available to them on that day in order to predict the two key outcomes that we care about. On the left-hand side, the outcome is whether somebody verifies the next day. And on the right-hand side, the outcome is whether somebody will have a poor treatment outcome. The key pattern that you should take away from these tables is that on day 0, we're not much better than a coin flip. Whereas later on, as soon as we get a little bit of data, we start to get pretty good at predicting these two key outcomes. How good depends, but we get pretty good at it. How can you see that from these graphs? Well, these graphs are graphs that show you area under the curve. On the x-axis, and that's a standard measure of the performance of a machine learning algorithm. On the x-axis, you have the false positive rate. On the y-axis, you have the true positive rate. And you want the false positive rate to be as close as possible to 0, and the true positive rate to be as close as possible to 1, meaning you want to spend as much time as possible in the top left corner. The more time you spend up there, the better this machine learning predictor is. So you want a really concave curve here. That means that the area under it is bigger. The bigger that area, the better the predictor is performing. If the predictor is performing along the 45-degree line that you see there in blue hashes, then it's performing the same as a coin flip. It's not really performing any better. So we don't want to be there. We want to be above it. The more above it, the better. And sure enough, now that you know how to interpret these things, you probably see the pattern I mentioned earlier. On day 0, things look like they're pretty close to that 45-degree line. It's not really much better than a coin flip for both of these. A little bit better for predicting outcomes, and that's because things like your gender and your HIV status and your age do predict to some extent how you're going to, whether you're going to complete treatment. But already by day 10, our curves become very curved. That means our ability to predict, both having low false positive rates and having high true positive rates, our ability to predict is becoming very good. It's especially true for next day verifier. We're especially good at figuring out who's going to verify the next day. We're not nearly as good at predicting who's going to ultimately complete treatment. That's something we need to keep in mind when we design our intervention, but we are quite good at it still. The area under the curve is still in the 70s, and that's still a meaningful predictor. So that's information I think we should use. And so the key thing that I take away from this is a pretty promising outcome. If what I want to do is build an intervention where I tell the support sponsors, hey, here's some guys who both are likely to fail tomorrow, to stop verifying tomorrow, and are in this category of people who are likely to fail to complete treatment. Could you reach out to them? Could you see what's up? That might work. Our predictors are good enough to provide our support sponsors with good information at that point. Now the question is, can we build a compelling intervention with our support sponsors and with a little bit of behavioral science that then, before the patient even stops verifying,
think we had a bit of an audio issue for the end of that. So I would request that we take one question just for time, but if you have any thoughts for the rest of that, I think a few minutes at the end of the presentation, we'd be happy to hear from you live on those. Thanks.
I think you guys probably get the idea. The question is whether we can design that intervention, and I was just being long-winded in asking it.
So thank you, Erez. I don't see any questions on the chat forum, but I do have a question for you, if I may. Is this intervention individual patient specific, or can that be translated into a community or a clinic or a certain region, or is this individual patient specific, this AI model?
The AI model is individual patient specific, but it can take into account information that you give it at the clinic level or at the regional level, and so it could incorporate anything from like the weather or things like that into its prediction of whether somebody should receive outreach and what kind of outreach that individual should get. Right now, we're very focused on a very particular outreach, but something that you could imagine expanding to is different kinds of outreach and predictors that predict different kinds of things and incorporate information at the clinic level or at the regional level to do that.
Very good, thank you. Alex, would you like to close it?
Thank you so much to my esteemed co-moderator and also to all of our presenters for this session. I think we really got a good cross-section of the different interventions here and the different sort of things happening in the data space for TB. So for our final presentation session, I would like to introduce our two moderators who will lead a panel discussion among different NTP leaders and who will lead a discussion among different TB survivors. So I'd like to welcome Dr. Shen, a senior TB technical advisor at USAID, back to the moderator stage for a second session. And I'd like to welcome Dr. Falzone here in person for day 2. We heard from him via recording yesterday. So thank you very much. And without further ado, I'll hand it over to both of you.
Hi, thank you very much, everyone. This is Dennis Falzone from Geneva, and I'm glad to be with you and to see this very enthusiastic and interesting discussion. So yesterday I had to do a pre-recorded presentation, unfortunately, and today I can join you in person. We have to move a bit faster on the session because we have a bit less time. I think WHO values a lot the digital interventions and the use of these technologies. We have it well featured in the NTB strategy that was launched for the post-2015 period, and these technologies in their different forms prove useful to the programs, and in moments as well in challenging times like the COVID pandemic, they have been of use for different purposes. So with that, maybe I invite Kaiser as well to say a few introductory words before we move on to the presentation.
Great, thanks Dennis, and thanks to the organizers for inviting me back. I'm really excited for this session and for the panelists who are joining us. I think from our side at USAID, just thinking about why we care about digital health, I think as USAID, we really envision a world where people have access to information and services that allow them to have healthy and prosperous lives. I think in the context of COVID and our TB epidemic, this becomes more amplified, and the importance of ensuring data is available to those who can use it in this interconnected society. So I think it really aligns well with our USAID digital health vision. And I think I won't go into detail here for the sake of time, but it was launched earlier this year, and I think it really focuses on helping countries build their capacity for digital health and ensuring that they have these strategies in mind as they're implementing different disease program activities. And underlying all of that is that emphasizing the importance of having these digital health architectures that allow countries to build good foundations for all of these technologies that are being presented here today and yesterday. And so I think, from our side, we're very excited for all the work that's being done and even the work that has been done through TB Care 2. So With that, I think we'll turn it over to Dennis again, and he'll provide some background on the first piece of this session.
Right, thanks, Kaiser. And I think the NTP panel, which we are very privileged, we have 4 very senior members from countries which are in the forefront of the fight against TB and using these innovative technologies. So the panel objectives will be to share experiences on at country level, which is the topic here, about digital technologies for TB prevention, detection and management, and to describe how these technologies have been roped into the COVID response, and while maintaining, of course, their contribution to TB prevention and care, and also to discuss the inclusion of digital technologies in future TB efforts in care and prevention. So maybe we can start by introducing the first member of the panel. I'll turn it over to you, guys.
So we're privileged to have Professor Nguyen Binh Hoa, who works as the Secretary of the Vietnam NTP, and he's also the Vice Director of the Vietnam Integrated Center for TB and Respirology Research. He's also a coordinator of the Global Fund TB project in Vietnam. Dr. Nguyen has been co-PIs on multiple research projects in TB. He's involved in the implementation, analysis, and writing of the first prevalence report in Vietnam in 2006. And he's also the current coordinator for the second TB prevalence survey that took place in 2017.
Right, and the second speaker will be Taya Letta. Taya is a senior public health professional specialist with a master's degree in public health, and he is the National TB and Leprosy Manager in his country and the lead for the technical working group of TB leprosy and TB HIV prevention and control since September 2017. He was a lecturer in public health and head of clinical department and members in research ethical review committee in Hosanna Health Science College before 2016, and currently Taya is working at the Federal Ministry of Health of Ethiopia as a national TB and leprosy manager, and his duties include the supervision of staff from national to regional level, and he's coordinating partner efforts and different agencies for TB leprosy prevention and control.
Great. And so we also have Celine Garfien, who is the medical specialist and is current designated NTP manager in the Philippines at the Disease Prevention Control Bureau at their DOH. She has more than 20 years of experience working in TB, initially as an implementer in a rural health center and as a program coordinator at the regional office and program manager at the central office. She's involved in the formulation of planning, policies and guidelines, as well as capacity building activities and conducting advocacy at the national level. She's also involved in the operational research aspect and providing technical assistance to the regional offices and partner agencies and other stakeholders.
Right, and last but not least is Dr. Shamul Islam, who is the Director of Mycobacterial Diseases Control at the National TB Control Program of Bangladesh since 2018. And he was the head of the department and vice principal of Sir Salimullah Medical College and has served as Director of Hospital Services Management for Directorate General of Health Services in his country. And Dr. Shamul was the Secretary General of Bangladesh Academy of Pathologists. Okay, so yeah, so with that, maybe we start the panel, and maybe Kaiser, you want to go for the questions?
Sure, yeah, and it looks like Dr. Shamul and Dr. Letta is having technical difficulties, so if they do get on and are able to answer, please let us know. But otherwise, we will move forward with the questions with our two panelists that are currently present. And so we just have a set of questions here that we would like just your input and feedback and to understand the current context for both Vietnam as well as Philippines. And so the first one is, how has the use of digital technologies for TB control changed in the context of COVID? As well, to what extent has COVID-19 changed the implementation of TB control in the community? And then lastly, what long-term changes to TB control programs do you expect as a result of COVID? And to what extent will digital health technologies play a role in this new sort of normal environment? And so with that, maybe Ms. Garfien, you can proceed.
Good morning, good afternoon, good evening, ladies and gentlemen. Thank you, USC and USAID TB Care 2 for inviting us for this event. We are glad to join this important forum to share our experience, thought and strategy about the implementation of digital health technology to TB in Vietnam. So for the question is the use of digital technology for TB control in the context of the COVID-19. Is it the digital technology is intensified to support patients and program through the improve the communication, counseling, care, and information management among the other benefits. So I think this is the using of the digital technology for TB control is very important during the COVID-19 pandemic because in the pandemic this is the lack of the communication, reduce exposure between the patient and the doctor. And on this opportunity, I would like to share some information apply the digital technology in Vietnam and some information for the TB in Vietnam. This is the Vietnam ranked 11 out of the top 30 high TB burden country, and it's 11 out of the top 30 high MDR TB burden country as well, according to the WHO 2019 report. And we estimated around 170,000 people developed TB in Vietnam in the 2019, and 9,400 people died from TB in the same year. And TB control is mainly depend on the community and is implemented by the whole TB and lung disease control network from center to local with collaboration from public and non-public health agency. The state takes the major responsibility for ensuring the adequate resources for TB prevention and control, while advocating for every social resources to support TB prevention and control activity. And looking forward to 2030, Vietnam National Strategy for TB Control aims to reduce TB mortality and prevalence to less than 20 cases per 100,000 population to eventually reach the TB free in Vietnam. The 4 key points of the plan include new thinking, new technology, new approach, and new investment. Harnessing new technology is key to achieving Vietnam's goal for ending TB by 2013. Innovative tools such as the double-X, chest X-ray, and gene expert, for example, is a key for increased TB detection. And for the digital health can be broken down into 4 main categories: patient care, surveillance and monitoring, programmatic management, and e-learning. And in Vietnam, we already implemented some of the digital health for improving TB activity. In this forum, we also seen the presentation from the World Cook Institute and the fifth by presentation by Luân Võ on the digital dosing monitoring for the applied ACES for V-Smart, and we also apply for the ZIG alert. Some activity we can see for the digital health. It is for the patient care, the support for treatment adherence. Like we also implement for the video treatment support, VDOS, for the MA health, for SMS, for send the message to support for TB patient, for reminding, for taking drugs, for surveillance and monitoring, for the notification, recording and reporting system. We have a VTMS and also management for supply system, graphic dashboard from the VTMS. We started for install the ZX alerts in all the ZXpert machine in the country. We apply the ASIS software in order to refer the TB suspect also from the private sector and also from the HIV. GPS mapping, air reporting for the adverse event treatment. For programmatic management, we started to apply the diagnostic device connectivity like the ZX alerts. We apply the ETB manager and some application example for vSmart for the TB patient, for MDR TB patient, for management for the adverse event. For the e-learning, we also apply for ECHO, Zoom meeting, work-based training, and we started for some study on the AI for chest X-ray reading. In Vietnam, National Strategy for TB Control, information technology is identified as a mechanic for controlling TB by promoting surveillance and monitoring, checking, evaluation, and assessment for all TB service and health facility. Digital technology for TB has been crucial during the COVID-19 pandemic, allowing for patients to continue care while decreasing exposure for healthcare facility and protecting healthcare workers. In Vietnam, we also apply the ZXpert for detect for catches for COVID, for detect the COVID in the presumptive TB come to the TB hospital. And for the digital technology during the COVID-19 pandemic, we have to think of the telemedicine and e-training health education is a support for when in the situation of the new normal. We cannot organize the training and like the conference. So the technology will help for this, and the surveillance for the reporting, analysis, dashboard, and how to cooperate between the TB and COVID, and further support for the treatment adherence. This is my my thing about the question. Thank you.
Thank you very much, Dr. Huang. So I noticed that Dr. Taye Letta is joined us now. So maybe I invite comments from him and later Dr. Selina, if she's still online. I believe so, yes. So if you are ready, Dr. Taye, then speak now and address these questions that you see here. Thank you.
Thank you. This is Taye Letta from Ethiopia as National TV Program Manager. Thank you for inviting us. Just concerning of this three question and as experience of my country, Ethiopia, digital technology is very important for the country. So especially during this COVID-19, this digital health technology is very supportive for the country. So when we see as relate to the question, digital technology to support adherence to drug treatment for TB is one of our important area currently. The use of digital platform in the COVID-19 response has recently been highly highlighted in our country, especially the technologies that could be improved the TB treatment, like a short message service for the TB patient, as well as for screening of TB patient, treatment of TB patient. This is very important for the controlling of TB during the COVID-19. The other thing, especially currently, what was started in Ethiopia is the adherence follow-up with TB patient with digital technologies currently piloted, and this will be implemented for the future also, not only during the era of the COVID-19. So the other under piloted currently is video supported treatment for TB patient. So this is currently also under pilot. This will be also support for the TB patients. When we come to the second question, the extent that COVID-19 changed the implementation of TB control in the community. So currently, you know that COVID is highly influenced the TB control program, the TB prevention control as well. So even some modeling shows that 30% of TB patients are die during the COVID-19. So globally, almost 25% of TB patients is expect to reduce with detection of TB cases. So this reality is not only a global one, but it is true in most of the country. So even in our country, Ethiopia, when we see these things, COVID-19 is actually change many things. So for example, DOT is changed from daily follow-up to monthly follow-up to reduce the patient exposure to COVID-19. So the other thing is contact tracing for TB, especially contact screening, is also reduced because health profession has not go to the patient house to house visit for screening. So this is the area that changes occur during the era of COVID-19. So this might be bring many changes in era of COVID-19. So this is the area that COVID-19 may bring or change in the extent of COVID-19 that change the implementation of TB. The other thing is, third question is the long-term changes that TB control program expect as a result of COVID-19 is that so the long-term that will be expected with the change of TB control program, that expected will be that the day-to-day follow-up for TB treatment will be changed due to COVID-19. So this may be expected. So this will be continued with implementation of digital technology can support this. So patient may not follow their treatment daily to the daily to the health facility. So this can be one of that will be expect to change. The other thing is TB and the COVID-19 will be integrated for screening, especially what we'll expect is that currently most of the management that is the prevention area is similar for TB. So similar for TB as well as similar for COVID, especially clean coughing is one of the main similar for TB and as well as for COVID-19. So the prevention for TB and the COVID may be integrated for the future one. The other thing is measure that may taken as limited for TB as well as COVID-19 is in congregate setting may be integrated for the future. This is maybe the area that the long term that will be changed. The other thing is this the prevention area for TB, like administrative, environmental, and personal protection measures that be similar for both, so that will be integrated for the future, and that may bring one of the change area for COVID as well as for TB. So the other, at what extent will digital health technology play in this area? Or is the question of this? That's maybe I think it needs a policy brief. So policy brief academic report highlights that positive impact of digital solution on health outcome in low and middle income countries are very important. The other thing is technology also has massive possibility to strengthen governance, finance, and human resource for the TB program, optimizing integration and effectiveness. The other thing might be affordable technology are allowing us to rapidly leapfrog and overstretch to the procurement of this distribution of this system. So we can innovate at a time when a dashboard analytic provider for national TB managers with a real-time to information on the TB drug availability and at the TB clinic. So this is how much digital health technology will play a role in the new normal one, that is era of COVID-19 as well as the era of this TB. This is all. Thank you very much. Over to you.
Thank you very much, Taye. So I realize that we are pressed for time and we are really on the hour now, nearly. But it will be unfair, I think, to allow the other NTP managers. I think Selina might be still online. I'm trying to see maybe if she can give a few comments. Unfortunately, we won't be able to accommodate as much time as we'd like, and maybe she can speak to these three questions very quickly from, I think she dropped off. Yes, it must be getting a bit late in the Philippines. Yeah, if that's the case, I think, and if Kaiser agrees, maybe, she's online.
Denise?
Yes.
I'm online.
You are online.
Yes.
Please. Yes,
So,
sorry to have kept you. Okay.
Good afternoon to everyone. So for the Philippines, the use of digital technologies for TB control, what we can say is that with COVID-19, this has made us realize the importance of the digital technologies. And because we have our integrated TB information system, we were able to have our data even if our health workers are not in their offices because of the lockdown. So we're thankful for the digital technologies because we have the information. Then to what extent has COVID-19 changed the implementation of TB control in the community? So it has made the activities difficult because we stop our active case finding activities, our screening activities for our testing and diagnosis. Some of our expert machines were used for COVID. And then for the treatment, I would like to say that we became less, we were lenient in our policies because now we provided patients with 1 month of drugs, unlike before that we would request them to go to the facilities daily. So we were less lenient. And then we also gave more responsibility to the patient since they can now collect their sputum specimen at home. We just inform them what they should do. And then at the same time, with COVID-19, we are doing virtual trainings for our health workers. So for the number 3, what long-term changes for TB control programs do you expect? So for us to have the new normal for TB, we have our NTP adaptive plan. And with this plan, the digital technologies would be playing a great role since we will be using that when we do screening for our patients, when we do our testing and diagnosis, wherein, as mentioned earlier in the previous sessions, we have the data to care, system 1, and the integration of the electronic laboratory request form. Then for the treatment and the prevention, we will have our digital adherence tools, the 99 dots, the smart pills, and other TB or other digital adherence tools. And with digital technologies, we will also be having our guide TB for our manual of procedures. Then we have our race TB for our TB dashboard. And at the same time, we will be doing our IT roadmap because there are a lot of digital technologies in the field. So we need to have a roadmap to guide us on how we are going to use all of this and how we can adapt in the new normal. So that's all. Thank you.
Thank you very much. A lot of information and a lot of work. So yeah, so I guess with that, Kaiser, I don't know if you have any other comments to make at this point.
No, I think this was really great to hear such a diverse set of experiences that cut across both TB and COVID. I think it'll be exciting to see what sort of best practices come from a lot of these on-the-fly adaptations of what was originally meant for one program towards another. So thank you to all 3 panelists for sharing their experiences.
Yes, thanks. So maybe with that, I will introduce very quickly the 3 survivors that have joined the session. We see them here online. So there's Charmaine, Florita, and Zolelwa. And maybe I invite them in that order, and they can say something about themselves and then about their experience, and in particular, looking at the perspectives of use of digital technologies in their life. So Charmaine, I believe you're online.
Okay. A pleasant good morning. Okay. Very Can you hear
Hello,
me?
please continue.
Okay.
Yes.
Pleasant good morning, good afternoon, and good evening to all. My name is Charmaine Apello from Valenzuela City, Philippines. I am humbled by this opportunity to join you for today's discussion. Let me share with you my journey as a multi-drug resistant TB patient in 2009. I was terrified when I learned I have tuberculosis. much more to learn that my case was drug-resistant TB. I was confirmed with drug-resistant TB at the Lung Center of the Philippines. I drew my strength from my family since I had to endure 18 months of TB treatment. It was very challenging to go to the treatment center every day and have my medications there. Apart from the adverse reactions, I was fighting depression during the time of my treatment. My deepest thanks to the health center physician, TB staff, and barangay health workers who stood as my treatment partners, for they encouraged me to complete my TB treatment and provided counseling from time to time. I would go to the health center every day to receive my TB medicines. The assigned and TB nurse and health center staff religiously monitored my adherence to treatment. I salute them for their perseverance. In 2011, I got cured and became a member of the Alliance of TB Control Advocates in Valenzuela City in 2012, an organized group composed of members who are cured TB patients enrolled and treated in the health centers in Valenzuela City. After a year, I was one of the participants of the interpersonal communication and counseling for TB educators and treatment partners workshop, a project conducted by Impact, funded by USAID. As a TB survivor and advocate, I was invited as a resource person in focus group discussions, community assemblies, and bench conferences in the communities to testify and share my experience in TB treatment regimen on adverse drug reactions. During my term as ATCA president, I became the spokesperson of the group and a lead facilitator for trainings for IPCC to continue to new members who would like to volunteer as TB educator. Although we lack digital tools, we have a great network of health volunteers and community health care workers who monitor and supervise TB patients in the communities. I was very grateful that I survived drug-resistant TB. It felt like I am starting a new life. I got married and went back to work as a guidance staff, and now I'm now in a teaching profession. So we are proud that ATCA is very good in case holding for drug susceptible TB. We make sure that each treatment partner regularly monitors the treatment adherence of our enlisted patients. To date, there are about 50 active members and still counting. And to reach out to all of them and update each other about our activities for the TB program implementation, we use our Facebook and Viber accounts. So we have limitations using social media and mobile applications for our patients. Some of our patients have no internet connection until now. So recently, the city government of Valenzuela, ATCA, and USAID's TV platforms conducted a webinar that establishing and strengthening patient support group to improve TB treatment compliance and TB outcomes. This webinar is one of the series of activities that will engage our members and other local government units, as well as private partners, to look into innovative ways in strengthening TB response amid COVID-19. So maraming salamat po. Thank you for this opportunity.
Okay, thank you very much. So maybe I invite Florita now.
Thank you po.
Yes, good morning from the Philippines.
Hello.
It is hello. Hello, can you hear me now?
Yes, we hear you. Thanks. Yes.
Okay. Good morning from the Philippines. It is an honor for me and my organization, the TB Health Education and Livelihood Support Patient Support Group, to be part of today's webinar. I am Florita Dalida, and I've been working as part of a TB program implementation with USAID since 2018. In 2018, TB Hills was founded to provide psychosocial counseling, health education, and hopefully livelihood support to DR TB patients and their families. As a TB nurse, we explain the importance of treatment adherence and the need for a strong support system for TB patients to continue and complete their treatment. We reach our patients using text messages and phone calls. We monitor the status of our members' TB treatment through our Viber groups and Facebook Messenger group chats. Since there is limitations in travel due to COVID-19 pandemic, the use of digital technologies has helped us monitor patients' treatment adherence. Video DOT has effectively replaced DOT. Other digital applications were already introduced to us by the collaborative efforts of KNCV, WHO consultant Yohei Hamada, and USAID's TB platforms. And on behalf of TB Heals, I would like to express our excitement and willingness to embrace digital apps to better the delivery of healthcare services to our TB patients and program partners. We do not just treat the disease, we treat the patient. We treat the patient as family. We even have regular meetups so we can celebrate treatment milestones. During these celebrations, we try to incorporate TB education for our new members. We explain that as TB nurses, we ensure that patients are given the correct medication and treatment, but we also need their cooperation. In TB cases continue to rise, especially during this pandemic. TB Heals is working with USAID's TB platforms in promoting public awareness on TB symptoms and how to access TB services amid COVID-19. We just recently launched a children's storybook dubbed as Tibay ng Dibdib. This is based on the real-life story of our members, two young sisters aged 3 and 7, survived DRTB and DSTB. This story depicts the journey of these sisters during the TB treatment process. Tibay ng Dibdib also highlights the role of healthcare workers and TB Heals as the patient support group that paved the way for the family to cope up with TB treatment. The two sisters are now TB-free and they are in elementary school. In partnership with the Department of Health and USAID's TB platforms, we will continue to document real-life stories of our TB patients as we continue to promote TB education, raise positive health-seeking behavior, and help reduce the stigma of the disease. Using social media platforms and the regional media network, we hope that TB Heals will be able to contribute to the successful implementation of the NTB in support of the TB-Free PH campaign. Thank you very much for inviting me to join this event. To be here with all of you is another milestone for TB Heals. Maraming salamat po.
Thank you very much, Florita. I think that is very interesting. Thanks. And with that, maybe I ask the last speaker, Zolelwa, to speak to us.
Hello. Can everybody hear me?
Hello, we hear you. Please, go ahead. We see you as
Sorry
well.
about the light. Oh, wow. Hi. Hello. Okay, sorry about this. Hi, everybody. My name is Dr. Zolelwa Sifumba, and I am a community service medical officer from KwaZulu-Natal in South Africa. And yes, I'm also a multi-drug resistant. Basically, what happened is that as a medical student in 2012, while doing clinical work, obviously we were exposed to tuberculosis. But I think back then, there's this culture, and it's weird, it's changed now because of COVID, but back then, infectious diseases weren't really taken seriously. So as much as we as healthcare workers and students were at increased risk to get TB, we weren't aware of that risk. Anyway, I woke up one morning, I had a lump on my neck. I wasn't losing weight, I wasn't coughing, I wasn't having night sweats, none of that. I just had a lump on my neck. So I decided to get the lump checked out. went to the hospital. Basically, they did a fine needle aspiration at first, and they got nothing from that. But then a few days later, I went back and they did, they basically took a biopsy of the node, and straight away it looked like tuberculosis. So I was put on treatment. So basically, I don't really remember how everything went down, but I know I was basically given a period. I mean, I was tested, obviously, so I was waiting for the results. And on a Saturday afternoon, when I was chilling with some friends, got a phone call from the lab, and I was told I had multi-drug resistant tuberculosis. So yeah, I was probably in denial for the most part of it. But as a student, as a medical student, and as a South African, I knew that obviously, you know, a lot of the patients that I had seen in the hospital had come to me because they had TB, you know, and I happened to be working in a hospital that had quite poor IPC standards. And obviously everybody knows about IPC standards now, but, and that's another crazy thing I wanted to talk about, you know, the fact that, I mean, now that COVID is here, everybody is well aware of infection prevention and control. They're well aware of contact precautions. They're well aware of having to wear a mask and be socially distanced. When all of these practices, you know, were being used for TB, I think the only difference was that there's a lot less political will in the world for TB, even though TB is still, you know, and for the last, you know, however long has been killing millions of people globally, yearly. Because COVID is a new thing, and it's killing now and it's killing fast. I mean, people are saying that it's the first time we've been, you know, threatened by something like this, but really it's not. It's just that TB doesn't receive as much airtime as other diseases, and it's seen as a poor man's disease, and, you know, a lot of other things as well, you know. So yeah, as a medical student, having just found out that I was a high risk group for TB, it really was tough, you know. And the treatment side effects, I mean, I don't think there's one sort of TB survivor that doesn't talk about the terrible side effects. But yeah, I was sure that I was dying, either from the TB or from the drugs, or I was going to kill myself because I was depressed from the medication. And, you know, so back then, why I'm mentioning this is because back then I really struggled because there was a huge lack of support. I mean, and even now in South Africa, people haven't come to understand the fact that as TB patients, as people that are on TB treatments for extended periods of time, we struggle with adherence, not because, you know, we don't want to take the drugs, but the drugs make you feel really sick, you know. And I feel really fortunate to have been a patient before I became a doctor, because I have realistic expectations of people now, and I know sort of the kind of care I would have wanted. So basically, I feel like you know, the voices of TB survivors are needed, because it's basically us who are going to say that, okay, this is good, this is good, this is rubbish, this is rubbish, continue with this, you know. But anyway, there at that time when I had TB, I mean, there were no support groups online. I mean, the technological stuff was dismal, also because of lack of political will. But COVID has shown us that we can actually do all of these things. You know, we can have webinars like this where we're still talking, you know, we're sharing stories, we're teaching each other, but we're doing it in a way where there isn't, you know, a lot of, you know, risks of infecting each other with infectious diseases, you know. So we're having to be creative. And basically, yeah, my point here, and I'm closing off now, I'm excited because COVID has shown us what we can do, you know, with all the technology that we have at our hands. Sorry about that. I am in my car. Sorry. So basically, yeah, as I was saying, with all the great innovations that are happening now, and we're starting to realize that as a people, we're able to have these meetings in more creative ways, I think, and not just the meetings, we're able to actually speak and support each other in creative ways. And I'm excited, you know, for the support groups and the apps that are going to come, and, you know, the webinars where TB patients can speak to each other and motivate each other, and not just TB, but all illnesses, you know. So yeah, I think it's still lacking in the TB world as much as, I mean, I don't know, obviously there's been great presentations that have happened, and, you know, But in South Africa, I think, yeah, there's very little. I mean, I'm still having to support a lot of people sort of personally because there is no psychological support for people that have TB, you know? But yeah, anyway, thank you again for having me. Sorry for speaking so long, but yeah, thank you.
Thank you very much, Zorelwa. And with that, I think I would like with Kaiser to bring this session to a close. We've heard some really very good testimonials and very good experiences from the NTPs. Thank you very much from the side of WHO. We're always listening to these experiences and to hear from people's the creative things that they do to try and overcome this serious challenge and with added complications that COVID has brought to the scene. Kaiser?
Thank you, everyone. And I echo Dennis's sentiments, appreciate everyone's time. And this forum has been really great to highlight the successes and also looking forward to what we can expect with the technologies that are currently in place. And so on behalf of USAID, thank you again, and we'll move it back to the moderators.
Great, thank you so much, and thanks to all of our speakers for their inputs and their really unique insight and sort of really helping focus the event and the entire reason of sort of holding something like this and the point of any of these innovations, right? So with that, I would like to invite Hala Jassim Amasawi to deliver some closing remarks on behalf of URC and the TB Care 2 project.
Thank you, Alex. Thank you, everyone. This is really great. The sessions yesterday and today, it's amazing. The lessons shared by presenters, by organizations, and as we have reached the end of day 2 of this virtual forum, the Future Digital Health for Ending TB. With that, I wish to sincerely thank USAID TB team, TB Care 2 team at HQ and the field, our speakers and the organizations that they represent for lending their expertise to develop fascinating presentations and give their insights for us all to learn from. Thank you so much to NTP managers who joined us. It's very late your time, so thank you so much for also the patient support groups and TB survivors for joining us. I hope that we can all take these learnings to strengthen our efforts and outcomes in TB prevention, detection, and treatment as we navigate this COVID-19 toward steady and sustained development. And each of you here today bring incredible talent and expertise in your own approaches. And I'm a firm believer that we together can build the comparative advantages of USAID foreign assistance and sharpening strategic investments in the programs that are most likely to have a meaningful impact on building on activities, interventions, and projects that deliver sustainable results. Thank you again for joining and participating in this forum, and we look forward to the time where we come together again, share our progresses, our successes, and like we heard throughout this forum, as we advance healthier families and bolster inclusive development and strengthen resiliency among our partner countries. Thank you so very much again. Thank you, Alex. Back to you.
Great. Thank you. So I think for our concluding remarks, we'd like to introduce Professor Kenneth Castro. Professor Castro is the Senior TB Scientific Advisor at the Office of Infectious Disease in the Global Health Bureau of USAID Washington. He also holds academic appointments as a professor in the Hubert Department of Global Health and the Department of Epidemiology at the Rollins School of Public Health, and as an adjunct professor in the Division of Infectious Diseases in the Department of Medicine at the Emory University School of Medicine. Among other accolades, Professor Castro has been profiled in The Lancet as a public health hero. So without further ado, I'd like to invite Professor Castro to deliver some remarks.
Thank you so much. The hour is late, so I'll keep it very brief. I try not to be as repetitive, but on behalf of Sherry Vincent and the USAID TB team, I really thank the TB Care 2 team for organizing this important two-day virtual forum, The Future of Digital Health for Ending TB. I also echo the thanks to the excellent speakers for sharing their expertise and insight over the last 2 days. And I would also, at the risk of repeating what you heard from Hala, it is imperative that we now apply these lessons and innovations for accelerated progress in the global TB response. This is especially important at a time when we're all facing the COVID pandemic, where resources and attention has been diverted, as mentioned by others during opening remarks and throughout this process, the two-day session. Including more recently, you heard from Solelwa about her own personal journey through this process. And to add insult to injury, there's modeling study that cites that we're at risk of losing 5 years of progress due to the response of the global response to the COVID pandemic. We can certainly not afford to continue business as usual, and we really need to apply these innovations with attention to patient-centered care for accelerated progress. It would be wrong not to acknowledge that this forum is a bittersweet achievement, because it does represent the last event organized by the TB Care 2 project, which is slated to end this year. This project was one of USAID's flagship global TB projects and achieved great results over its 10-year span. As the US government leader of global efforts to end TB, USAID remains committed to unleashing our full collective potential to deliver meaningful development outcomes while empowering partner countries along their journey to self-reliance. This is being done by working with other agencies and partners, including affected communities around the world, to reach every person with TB, to cure those in need of treatment, and to prevent the spread of new infections. I reiterate our gratitude to all of you for joining and participating in this two-day forum, and we look forward to the time when we can gather again to share added progress, including additional success stories as we strive towards ending the TB pandemic. Thank you, stay healthy, and stay safe. Appreciate it.
Thank you very much for the insightful remarks. And I'd also like to thank everyone for attending the forum today and yesterday if you were able to attend. I would like to also mention that we do have additional presentations, materials, and resources on the website for your benefit. And with that, I wish you a good day, a good evening, or a good night.